We are live.
Yeah. We are.
Ma'am, just give me 2 minutes.
Okay, fine.
डॉक्टर अर्चना कुमारी का फोन नहीं उठ रहा है मैम।
आ जाएंगे।
अच्छा,
अभी हम लोग का इनॉग्रल है सेशन, थोड़ा लंबा है।
Dr. Bharti, you are muted. He's talking something I think.
Ma'am, we are live now. We are good to go. So, very good evening, all the respected faculties and delegates present over here. On behalf of Corona Remedies Private Limited, I, Vasisht Mehta, welcome you all for the COR Connect live webinar organized by ISOPARB Gorakhpur chapter and Gorakhpur Obs and Gynae Society on the theme of every gynecologist is a preventive oncologist. For the session, I invite Dr. Amrita Jaipuriar ma'am. Ma'am is secretary of ISOPARB.
It's okay, Vashisht.
Yes, ma'am.
Let's move.
Over to you, ma'am.
Thank you so much. A very good evening to everyone. On behalf of the Gorakhpur chapter of ISOPARB and Gorakhpur Obs and Gynae Society, I welcome you all to this star-studded webinar on preventive oncology. Cancer still is the most dreaded disease despite all the success which science has made. It is almost like a death certificate for the patient months and years before her death. Preventing cancer and its early detection is the best which we can do. And so this program has been crafted. For today's program, we have all the learned, dazzling, and magnetic personalities of FOXY and ISOPARB on board on this platform. We have Dr. Kamal Bakshi as our chief guest, Dr. Ram Prasad Dey and Dr. Madhuma T as the guest of honor, Dr. Kiran Pandey, Dr. Archana Kumari, Dr. Geeta Goen, Dr. Bharti Mishra, Dr. Bharti Rajshekhar, and Dr. Reena Srivastava as chairpersons, Dr. TV Chitra, Dr. Sadhna Gupta, Dr. Anjana Chauhan, and Dr. Kanchan Sharma as speakers. So in the beginning, let's invoke Lord Ganesha and seek his blessings. Start the video, Vashisht.
Vakratunda Mahakaya Suryakoti Samaprabha Nirvignam Kuru me Deva Sarvakaryeshu Sarvada.
Light signifies knowledge, strength, prosperity, and positivity. So let's get some positive vibes. I request all the dignitaries, faculties, and the attendees to join us for the lamp lighting. We are honored to have with us today the very dynamic and learned Dr. Usha Sharma, Madam, National President of ISOPARB. May I have a CV, please? Madam is very clear-sighted, discerning, and observant, quick-witted, affectionate, empathetic, devoted, and very, very down to earth. We are all inspired by her. Welcome, Madam. Madam is the President ISOPARB, consultant, and very, very famous. Ma'am, we seek your blessings. Over to you, ma'am.
Can you hear me?
Yes, ma'am.
First of all, Amrita, thank you so much for such nice words for me. I thank you from my core of my heart. Now,
You're welcome.
before I start my welcome speech, I would like to request you all to please vote for Sadhana Gupta, who is a brilliant academician, a brilliant clinician, and a worthy candidate for ISOPARB president. Now I start with my welcome. The theme today, webinar, really strikes my chord. Yes, every gynecologist is a preventing oncologist. In fact, a thorough clinical examination reveals a lot, be it breast or gynecological malignancy. A thorough examination of the breast along with breast imaging and FNAC as an adjunct helps in prevention and early detection of breast malignancy, which is curable nowadays. Clinical examination of the pelvic organs, per speculum along with pap smear, colposcopy where needed, helps in detecting many precancerous and cancerous lesions of the cervix. HPV testing and HPV vaccination is another useful measure for prevention. Prevention is better than cure. Can't be more true than in cases of malignancies. I congratulate Dr. Sadhana Gupta and Dr. Amrita Jaipuria for today's webinar's theme on common gynecological cancers, how we can prevent them. I extend a very warm welcome on behalf of ISOPARB to our beloved past president ISOPARB, Dr. Kamal Bakshi. As we all know, Madam was the Obs-Gynae professor at AIIMS Delhi who introduced many new things in the department. I feel honored to welcome her. I am delighted to welcome Dr. Reena Vani and Dr. Reena Srivastava, who are always supporting ISOPARB Gorakhpur with their guidance. I extend a special welcome to today's guests, Dr. Ram Prasad Dey, Dr. S. Madhumati, and our worthy Secretary General Meena Samant in today's webinar. I am sure that the learned speakers for today, Dr. Sadhana Gupta, Dr. T.V. Chitra, Dr. Anjana Chauhan, and Dr. Kanchan Sharma is going to update us with all the modalities of screening in gynae oncology. I welcome all the chairpersons who have spared their valuable time to update us further. I welcome all the viewers. Happy learning and long live ISOPARB, as I always say.
Thank you, ma'am. Thank you for the wonderful and encouraging words. Now, I would love to invite our leader, the artist and the designer of this program, very empowered and resolute, the symbol of brilliance. Dr. Sadhana Gupta, ma'am, please, you're welcome on the dais to introduce and invite our chief guest, Dr. Kamal Bakshi, ma'am. May we have the CV of Kamal Bakshi, ma'am?
Thank you, Amrita. Bakshi, please share. It is my pleasure to invite as a president Gorakhpur chapter of ISOPARB all dignitaries, all faculties, and all participants who are with us on this day. This is a oncology day we have celebrated on 4th of February, and it is in the same continuation we have designed this program with the theme that every gynecologist is a preventive oncologist. And to grace this webinar, we have none other than Professor Kamal Bakshi, who has been a mentor figure for all over gynecologists, not only in India, I can say across the world. She has been former professor at AIIMS New Delhi, India. At present, she is senior consultant at Indraprasth Apollo Hospital and Fortis Law Firm and emeritus professor of National Academy of Medical Science. She has been the always visionary, and we see till today that act much before the times. She is first timer world and India ultrasound guided fetal skin biopsy in 1988, when the fetal medicine was not a known word to all over the world, I can say. First, India uterine fetal blood transfusion, uterine balloon therapy, which we are taking now to all the periphery, all the program for management of postpartum hemorrhage. And she started Department of Fetal Medicine at AIMS. Awardee of Dr. B.C. Rai National Award for Eminent Medical Teaching, Lifetime Achievement Award by FOXY and Gynae Society of Delhi, Bharat Jyoti Award, Indo-Norwegian Scientist Award, a living legend title given by International Journal of Gyneplastic Surgery, and by all of us, we see her as a living legend. And Dr. Kamla Bakshi Oration is instituted in recognition of pioneer work in fetal medicine in India. She has been our FOXY president and president of ISOPARB and more than 250 national and international journals. Madam, we are really honored to have you on this evening. Kindly give your words of wisdom and blessing to us, all of us.
Good evening and namaskar to each one of you. First of all, just as Dr. Usha ji said, Dr. Sadhna ji, I would say you're always cool, smiling, and you have been teaching so much, I feel that you are the right person and you deserve. And I really feel that you take this chair, and our wishes with you. Dr. Usha ji and Dr. Ram Prasad ji, mostly it is the men who are there, and today, I don't know, Dr. Ram Prasad ji, that we are slightly in more numbers, but you are our special person. Dr. Madhumita ji and Dr. Meena. I would say, since the time is short, but what is very important is India is a vast country. And I remember as students, we could not proceed. We were taught as the patient walks in, observe her gait, observe her expression, what is there on her face, then you welcome her. And we examine the patient. That start with the breast examination, very important. And then abdominal and pelvic. And we used to say that examine the cervix, which gives you the history of the woman, and some cervix, they are smiling, happy, and there are others, so many lesions, which you call the cyst and that. In the same way, and nowadays we get patients who do not want to lie down. No, ma'am. Then they say, please don't examine. But the preventive oncology starts with, the patient walking if she comes. India is such a rural country, and the majority of the women are dying. Breast carcinoma cervix is the one. And if you all make a promise that we should examine the cervix of each and every lady, examination itself is very nice. Now, in India, the government is taking a lot of lead, so that the carcinoma cervix, we have a preventive, as you beautifully said, prevention is the most important. So on one hand is the preventive, the young girls who are coming, vaccinate them. Then the women who are 30 and beyond, in their cases, preventive is very important. PAP and HPV. And if ICMR or somebody can make HPV test, which should be cheaper, affordable, but till the time that our acetic acid and Lugol's iodine. And I would say that since the time is short, we must go rural, think rural, get district, and all unite together so that we save our women. I must say, each one of you are taking care of the women, and that is why our young generation, that means the children are being looked after. We are looking after the women, saving the nation. And thank you. I learned so much from you, and every day is a learning exercise. And my pranam, again Usha ji will say pranam.
Madam, please don't say pranam to me. You have been my teacher. You can't say that. No, please.
अब
You
क्या
can say
करें?
Ashirwad. You can say Ashirwad. Your blessings I'll take.
Yes, आशीर्वाद. लेकिन आप लोग इतना अपडेट करते हैं, नॉलेज देते हैं, तो ये कैसे कहें कि हम ये दीक्षा खाली हाथ ले लें? तो ये I would say it is such a treat, and thanks to all of you. You give life to the seniors, you know, by the warmth, by the pleasure and the smiles. Namaskar and Ashirwad to all the younger generation.
Yes.
Thank you.
Thank you.
Thank you so much, ma'am. May you live long and have a very healthy life. Thank you. And keep spreading knowledge and be with us.
Thank you.
Now, most of us have grown up watching her as an ideal, the captivating personality, confident and skilled surgeon, disciplined, punctual, and a great teacher. She is none other than Dr. Radha Jeena, ma'am. Madam, please grace this platform and welcome our guest of honor, Dr. Ram Prasad Dey. Over to Madam Jeena.
Thank you, Amrita, for your nice words. It is my proud privilege to welcome our guest of honor, Dr. Ram Prasad Dey. He is Professor of Obs and Gynae, CSS, College of Obs and Gynae and Child Health. He is Honorary Secretary, Bengal OBG Society. He is National Executive Member, ISOPARB, 2020-22. National Corresponding Editor, JOGI, 2021-23, and Joint Editor, Indian Journal of Perinatology and Reproductive Biology. Has various awards to his credit. Foxy Mrs. Chandravati Devi Jagannath Singh Prize for Best Paper in Oncology, and Foxy Golden Jubilee Cesara Award Best Paper for Immunobots. He has more than 45 publications in national and international journals and peer reviewer of different journals of gynecology and obstetrics. He presented more than 40 papers in different forums, and he is author of chapters in various books and Foxy Focus. Now I welcome you, sir, and I invite you for your words of blessing.
Thank you, madam, for your kind words. Good evening to everybody. Am I audible?
Yes, sir.
Yeah.
Hello. Yes, sir.
Yes,
we can hear you.
Good evening. Yes, good evening to everybody. Respected all, particularly respected today's our chief guest, Professor Kamala Bakshi, madam. Our president of National ISOPARB, Dr. Usha Sharma, madam. Second president, particularly President Gorakhpur branch ISOPARB, Dr. Sadhana Gupta, madam, and the secretary, Dr. Amrita. All the dignitaries in the dais, particularly the patron of the ISOPARB Gorakhpur Society, Dr. Radha Jeena and Dr. Reena Srivastav. Our own, my co-guest of honor, Dr. Madhumati, and also our own Secretary General of National ISOPARB, as well as today's special guest, Dr. Meena Samant, and all the today's faculty. It is my privilege and honor to be here with us, with you, in this prestigious this platform, along with the so many dignitaries in the dais. Yes, I am honored, and many thanks to the organizer, particularly Dr. Sadhana Gupta, madam, and the secretary, Dr. Amrita, for inviting me in this stage. Yes, today's topic is very interesting, and it is the theme of this today's is the continuation of the World Cancer Day. I think all of you know the 4th February is the World Cancer Day. It was initially started in the year 2000s in the from Paris, with these few oncologists as they are wanting to increase the awareness among not only to the patients, also to the relatives as well as the doctors. From this day we are celebrating. Yes, I agree with all of you. This COVID pandemic, so many problems we are facing difficulty, and we have also postponed our ISOPARB conference also. But if you look at this, yes, we have lost also so many of our colleagues and friends and relatives in this COVID pandemic. But if you look at this dreadful disease, the death is more due to cancer in the more than that of this COVID-related death. In the data shows the global data of 2000 that we have lost 10 million people for premature death due to the various cancers. And India being one of the largest contributor of the cancer presence, cancer survival, as well as the cancer-related death. So if we look at the Indian current scenario and today's world cancer day theme, it is the bridging the gap, bridging the care gap. Who will give this bridging this care gap? Here the today's seminar, that is the every gynecologist should be oncologist, because if you have to bridge this gap between the gynae oncologist or medical oncologist, a radiology oncologist, it is the gynecologist and gynecologist who will make this gap in between these two, because the most of the gynae oncologists or radiation oncologists are not available in the even the I also metro city also. They are also so busy with the giving the tertiary care. Today's thing is the preventive oncologist. If we consider any disease of prevention, primary prevention, it is the health education and specific protection. And there is basically no role of the super specialty gynecology oncology. There is the role of general doctor and also the female genital cancer. It is the gynecologist is responsible. If we look at the secondary prevention, that is the early diagnosis and treatment. I am working in a government medical college where is the attached, there is another cancer institute that all of you maybe know, the National Cancer Institute, Chittaranjan National Cancer. Unfortunately, I also say here that they only took the confirmed malignant patient for operation. They are not do some definitely some society work, but in their clinics or hospital, they generally do not admit the patient who is not previously diagnosed as a cancer service or endometrial service. They never go for the abnormal uterine bleeding screening. They send the patient to us in our medical college. After confirming the diagnosis, they took the patients. So it is the role of this gynecologist, general gynecologist is here, that you should give the early diagnosis so that the patient gets proper care. I also highlight that if you look at this female genital cancer, we have earned little that the cervical cancer is coming down in the third position in India. First being the breast cancer, second some data shows that is a leaf and oral cancer. Now the cervical cancer is third position. It is for us. We have tried, though our effort is little, but still we have subsequently reduced the cervical cancer incidence in our country. So keeping in hope, I must thank the organizer because they have chosen beautifully the 4 topics, including the breast cancer, which is the leading cause of cancer in India right now. And they have chosen the 4th. We are fortunate enough to have with us the 4th speaker, Dr. Sadhana Gupta, is going to talk on the ovarian cancer. Dr. T.V. Chitra Madam is also going to talk on the cervical cancer. Dr. Kanchan Sharma is going to talk on the breast cancer, and Dr. Chauhan is going to talk on the endometrial cancer. So I hope that this seminar or the CME will be helpful to us and also the delegates. I wish the every success of this CME. Thank you all the dignitaries, and thank you once again the organizer giving me the opportunity or inviting me here. Thank you once again, madam.
Thank you, sir, for
Yes.
your inspiring words and blessings. Now, moving on the next step, I'm sure all of us are going to get an overdose of sugar.
Yeah.
I'm going to invite the very popular, multi-talented personality, the amicable and affable, very intelligent and witty, our immediate past president of Gorakhpur Obs and Gynae Society, Dr. Madhu Bala Sharma ma'am, to invite and introduce our guest of honor, Dr. Madhumati. So 2 Madhus and overdose of sugar. Over to you, Madhu ma'am.
Thank you so much, Amrita. And it is so apt that you have invited one Madhu to invite another Madhu, and that too from 2 parts of India. And though Dr. Madhumati has given a very short CV, I think that her actions have always spoken more than what she says. She is a senior consultant of obstetrics and gynecology of Apollo Hospitals, Hyderabad. In her 8 areas of interest are high-risk pregnancy and adolescent gynecology. And now over to you, Dr. Madhu, to spread some more sweetness. I did what I could do. Now, please, some words of sweetness from you. Thank you.
Thank you, Dr. Madhubala. And big namaskar to all my seniors over there. It's such an honor to be sharing the dais with all of you. Special thanks to Dr. Sadhana and her team for this honor and making me part of your program. Like the speakers who have spoken before me, we all know that there's a huge burden of cancer, both globally and in India. And coming down to, yes, like Dr. Day said, we have now cancer cervix, which used to be the leading cause of female cancers, has now gone down to the third position. And yes, cancer breast is leading, which means we need to do more work in that area. I totally agree, and we all understand what Dr. Bakshi was speaking about, that nowadays patients don't want to lie on the couch, they do not want to get examined and all of that. So I think prevention, as the tagline of today's seminar is so apt, every gynecologist should be a preventive oncologist. And to be this preventive oncologist and to help our women understand why we are doing this or what needs to be done, I think the first step is to create awareness. Speak to our women, spend a little more time. They may come for some other problems to us, but I think we should kind of do something called as an opportunistic counseling and talk to them about why they should be getting their regular pap smears, teach them about self-examination of breast, tell them to come regularly for a clinical examination of breast, especially adolescents. We see a lot of adolescents who are visiting you maybe for irregular cycles, PCO, things like that. Again, use this opportunity without any judgment, but speak to them about safe sexual practices, speak to them about HPV vaccination, talk to the women about protecting their girls from cancer cervix by making sure that they got their HPV vaccine when they're an adolescent itself. We know that obesity and poor lifestyle choices are high risk factors for all these cancers. So again, we should speak to them, counsel them well about having a healthy lifestyle by, being diligent about their diet and exercise. Talk to the girls, especially the young ones. I would say catch them young. So talk to them, help them understand what is their ideal weight for height. Once it is, they understand the entire concept about why we are talking to them about ideal weight for height. And if they start their healthy lifestyle when they are young, then it will keep them in good stead through their life. So that is also a thing we should be doing. So as much as it is important that we examine them, we do their pap smear, we do a perspective examination, examine their breast. And then with these women who are not really willing for examination, so the first step is that we talk to them and counsel them well and tell them how they can prevent all these cancers. I won't really take much of your time. We have an excellent program. I'm really looking forward to understanding what are we doing about the cancer cervix burden by way of screening in our country. We know that both uterine and ovarian cancers are usually, unfortunately, detected at an advanced stage. So I would really want to know what the recent guidelines are about how we can effectively screen women for ovarian and uterine cancer and how each one of us can be a preventive oncologist. Thank you again, ISOPARB Gorakhpur, for this honor and looking forward to being part of your program. Thank you.
Thank you so much, Dr. Madhumati, for the guidance and the wise words, because it has been proven beyond doubt that a healthy lifestyle can be helpful in preventing cancers. Well, this is the time for some official hearing and announcements. So I'm going to invite the lady with the sweetest voice I know, very astute and savvy, Dr. Meena Samant, ma'am. Dr. Meena Samant is the senior consultant and head of the Department OBGY, Gurji Holy Family Hospital, Patna. She is the Secretary General, ISOPARB, and she has been the held many posts in Patna OBGYN Society, and she has been the recipient of awards and published many papers.
Dr.
Over to you, ma'am.
Yeah.
Over to you, ma'am.
Thank you so much. And at the outset, thank you organizers for inviting me and giving me the opportunity to be here amongst the stalwarts. Gorakhpur's chapter and the Obs and Gynae Society of Gorakhpur, they're so active, always, both academic and otherwise. Only recently we were here in Gorakhpur and seeing Dr. Madhubala, Dr. Babita and all those, we just remember their talent is, it could beat any professionals, even in culturals. So as talented as that they all are. Well, for the official thing, as you all know by now, that our conference has been shifted to May. That is 6th, 7th and 8th of May. We are all meeting physically in Varanasi. Respected chief guest of today and a very revered Dr. Kamal Bakshi, our president, Dr. Usha Sharma ma'am, Dr. Sadhana Gupta ma'am, Dr. Jeena, Dr. Jaipuria, all these, Dr. Reena Srivastava ma'am, Dr. Chitra, all the faculty, the stalwarts here on the screen, off the screen. Good evening, namaskar. I bring greetings to you from the head office of ISOPARB, Patna. Yeah, it's, awareness, like everybody has been saying, apart from what we as doctors have to do, awareness is one very important thing for cancer prevention. Only yesterday I was listening to a warrior of cancer breast who was also a doctor herself. And she told that 21 years ago, when she was diagnosed with a lump and she was waiting biopsy, which actually came out to be cancer breast, having had taken, the surgery and the chemotherapy, she's there a very, I could say, she's making a lot of difference in so many lives. She said when she was first diagnosed, her 8-year-old daughter asked her, "Mother, are you going to die?" So that is the kind of but yes, prevention, early diagnosis, everything goes in giving life a new meaning. And it's so nice that now ISOPARB is going to do a lot of it is been doing. This is a part of the awareness, activity, not only for the doctors, but for the general population at large. Dr. Usha Sharma and other members, they formed a committee, and also we're talking with some of the pharmaceuticals, and we may be coming out with written and even online version of patient awareness, which through all our members, we would want to reach to general public. So that is a awareness campaign we'll be taking. And Dr. Usha Sharma, she's doing some good work on that, and many other senior members doing. So we look forward that it will take off, and all our members, through our members, it will go to the public. So the topics, they are marvelous. I'll be sitting through and learning all the details from you. Thank you. Long live ISOPARB. Jai Hind.
Thank you, Dr. Meena. Long live ISOPARB. So now we move on to the clinical session, and I hand over the platform to the very hardworking and dependable, the chirpy and bubbly Dr. Babita Shukla. Over to you, Babita.
Thank you, Amrita ji, for such kind words. Today we have a galaxy of stars with us. We have met them personally in our ISOPARB conference, hence the bonding is even more. So moving forward to our first scientific session. For this, we have to talk on screening of cervical cancer in India. Where are we? And screening of ovarian cancer, updated recommendation. For this first session, I would like to invite our esteemed chairpersons, Dr. Kiran Pandey. Madam is Professor Head of Department of Obs and Gynae, GSVM Medical College, Kanpur. She is ICOG Governing Council member and President Kanpur Menopause Society, Chairperson IMA WDW, Vice President UPCOG and UPA-GOI, ex-principal GMC Kannauj. She has a vast work experience more than 36 years of teaching experience and contributed chapters in various books. Madam is recipient of 15 national, 10 state level and 10 district level awards and more than 40 awards by IMA and Rotary Club. She is recipient of Best Teacher Award and received President Appreciation Award. Warm welcome to you, ma'am. Now I would like to welcome Dr. Geeta Gui. Please, Dr. Geeta is Professor Government NSCB Medical College, Jabalpur, a dedicated teacher and a great learner, critical care obstetrician and endoscopic surgeon. She is President Jabalpur Obs and Gynae Society, East Zone Coordinator, Ethics and Medical Legal Committee, FOXY. A warm welcome to you, ma'am. Our next chairperson, Dr. Archana Kumari. She is Associate Professor, Department of Obs and Gynae, RIMS Ranchi, Master Trainer, EMOC and HIV TOT. She's Secretary, ISOPARB Ranchi Chapter and Executive Member, ISOPARB. She's Founder Secretary, IFS Jharkhand, East Zone Coordinator, Quiz Committee, FOXY, Convener Clinical Research Committee, Vice President Ranchi in 2019, and Organizing Secretary of conferences like ROGS 2009 and ISOPARB 2019, presented paper in national and international conferences and has several publications in national and international journals and contributed chapters in books. A warm welcome to you, ma'am.
Thank you,
Babita, Dr. Kedan, कुछ issue आ रहा है join करने में, so I have resent the link. So I will request Dr. Archana Kumari to introduce Dr. TV Chitra to take the first session. Dr. Archana Kumari, please.
Yes, ma'am. Can I have the CV?
I hand over the dais to our chairpersons and I request Dr. Kiran Pandey ma'am to introduce our speaker, Dr. Chitra.
Hello. At the outset, I'm very thankful to Dr. Sadhana and the ISOPARB, and my respect to all the chief guests and the guest of honors for giving me this opportunity. And I'm very thankful that I have to introduce Dr. Chitra. Dr. Chitra is Professor and Unit Chief of Obstetrics and Gynecology. She is at Tamil Nadu, Coimbatore, and she is affiliated to COR ONG Society, Scientific Committee member of Yuva FOXY 2019, member of IUGA and ICOG. So many affiliations, a very talented. It's an no.
Make it
I mean,
short,
this is I know, doctor. I know you are a well-known personality, and your interest into the academics, urogynecology, high risk, and of course, you have a great academic knowledge. So we are all waiting eagerly to listen to you. So I will not come between you and my viewers. Again, I would like to say thanks to Dr. Sadhana ji, and I'm there and I will listen to you throughout. Thank you so much.
Can I share my slide?
Yeah, you share, please. In the meantime, I just wanted to say the cancer cervix, all of us know it is the second most common cancer for the death in females from the cancer. And unfortunate thing is that though we know, all of us know that it is a preventable cancer if timely detected.
Thank you, ma'am. And good evening, respected Kamal Bakshi madam, Radha madam, Ram Prasad sir, Usha madam, and all the other dignitaries. I bring greetings from Coimbatore. I thank the ISOP for having given me this opportunity, Gorakhpur Society, Dr. Amrita, Dr. Reena, and a very, very special thanks to Sadhana ma'am, who really asked me, please, could you talk about this? Thank you so much, ma'am. And I'm really delighted
by the topic, which says every gynecologist is a preventive oncologist. That is very, very true. Because once they become an oncologist, they're very busy operating on cases or doing the medical treatment or the chemotherapy, whatever it is. But as gynecologists, we play a very important part in preventive oncology. So that title is very, very apt, ma'am. And I'm sure, and I hope that all gynecologists will live to it. So the outline of my talk is, I'll just give an overview about cancer cervix. What are the WHO goals? What are the screening strategies? What are the methods of screening which is available in our country? And of course, what are the barriers to screening and what is the paradigm shift? Now, as already mentioned, the leading cause of death in India, apart from heart disease and circulatory disorders, which ranks first, cancer is the second most important cause of deaths in India. And as far as women are concerned, the two cancers which are important is, the leading one is breast, followed by the cervical cancer. Now, this is a chart, which is a graph, which is showing about the world statistics about all NCDs, which is the non-communicable diseases. And this is specifically about cancer cervix. And it shows that the incidence of cancer cervix is roughly around 4 times much more than what is there in the Western countries. If you see North America and Europe, it's only around less than 7 per 100,000 women, whereas we are somewhere around 25 to 26. So we have 4 times much more cases than the other counterpart of other countries. Now, GloboCan in 2020 said there's roughly around 6 million new cases of cancer cervix every year, and of it, 342,000 deaths occur every year. Now, what about India? In India, roughly 120,000 women develop this disease, and India accounts for roughly around 15 to 20% of all the total cervical cancers in the world. So all roughly around 15 to 20%, that's a huge number we add to the burden of cervical cancer in India. So is it not important that we do something about it to prevent cervical cancers? As obstetricians and gynecologists, I'm sure we could all do it. Now, worldwide, 1 woman dies from cervical cancer every 2 minutes. And what about India? 1 woman dies of cervical cancer every 8 minutes. Now, all this, it's indeed very funny to have so many people dying of cervical cancer, because cervical cancer is preventable. There are 2 important things. Cervix is very, very easily accessible, which makes us look at the cervix and then see what is happening in the cervix. And secondly, when you identify them in the pre-invasive stage, it takes many years for it to become invasive. So having these 2 things, we should not allow any person to die of cervical cancer. But in reality, that doesn't happen. This is a chart which is showing it roughly takes around more than 10 years for a person to have a low grade to move on to a invasive cancer. So we have 10 years to detect a cancer and then detect a pre-invasive cancer and then prevent it. Isn't that a lot of time for us to do something about it? Now, in 2018, the WHO said it took a call to eliminate cervical cancer. And it said it brought about these goals. But 2020, we have to follow 90-70-90. What is this 90-70-90? 90% of all girls less than 15 years should be vaccinated. That is first. The second one is 70% of all women between 30 to 45 years of age should have a testing, a robot testing. It could be a PAP testing or it could be a HPV testing. A robot testing should be done for all women between 35 to 45 years. So 70% of the entire population should be covered. And again, 70% of all those women who are diagnosed should receive treatment. And of all these things, 30%, we should have a reduction of 30% overall mortality from cervical cancer, and that should be achieved by 2030. So we hardly have less than 10 years to achieve this statistics. So what are we going to do, and what are the screening strategies in our country? Now, for us, so for any screening strategy, we should have a target population. We should be using a method which covers all the target population, and we should be able to use a test which is very, very effective. Now, if you look into these, this is a picture about the incidence of cervical cancer in UK. So if you just see this picture, once they introduced this call and recall, the incidence of cervical cancer came down drastically. So in our country, for any screening program to be successful, at least 80% of the entire population should be screened, and you should use a test which has a very good sensitivity and a specificity. So you should be able to identify and then use this test. So there are various tests, but let us, as the discussion continues, I will tell you about all these tests. So there in UK, they use this pap smear, and once they started using this call and recall, and periodically people were called for a pap smear, they brought down the incidence to less than 2, and then now it is almost very, very nil. So what are all the methods of screening that we have? The age-old method is VIA and VILI. So VIA is visual inspection using acetic acid, and VILI is visual inspection using leukocytin. And then the same thing when you do it under magnification, you say VIAM. And then pap smear. And lastly, the newer one is the HPV sampling, which can be either done by the obstetrician, by the care provider, or you also have the latest, which is self-sampling also. So let us take up one method by each one by one. Now VIA, visual inspection of the cervix, is you use a freshly prepared acetic acid. That is very, very important. So every day you have to prepare the acetic acid. You can use, how do you prepare this 5% acetic acid? You take 5% of the glacial acetic acid and put it in 100 ml of distilled water. That will give you the 5% acetic acid. So when you apply this over the cervix, you wait for a minute. The faster it takes up the acetic acid, the more advanced the lesion is. If it takes a long time, it may be a very low grade lesion. So by just looking into the cervix after the inspection of acetic acid, you'll be able to know is there any changes in the cervix. That's a very, very simple method which does not require any training, which could be done by anybody. In fact, many years, maybe around 15-20 years, Dr. Shankar Narayan had started this camps in Dindigul, which is in Tamil Nadu. There, all the nurses were the ones who were doing these VIA. So these nurses were taken, they had huge camps, and I attended a few camps there. Maybe 200 people would come there. All these nurses would put this, and then they will just use a colposcope and just look under the colposcope after putting visual, acetic acid. And the advantage was that then and there they were treated. So those persons who had this VIA had the cryo then and there. See, in rural areas, it's very difficult for patients to come back again for another checkup because they have to spend one entire day. So these camps, mobile camps, were conducted in the rural areas themselves. Patients used to have a small makeshift area. It was just a small shelter where they were put on these beds, and then all the equipments were being transported by the hospital itself, and including the colposcopes. And then they used to treat them. Cryo was being done there. So that is the most important thing. See and treat was a practice which is being followed there. I think everybody could do this visual inspection in any remote center. It's not at all expensive. So that's the greatest advantage. Not expensive. It is easily available. You only have to do it every day, and then very, very cost effective. It can be used as a see and treat method. The other one is VILI. Now the only problem with VILI is if you have an ectropion, it might not take up this mephobony, and you can mistake it for a positive lesion, and it could be unnecessary referring these patients for colposcopy. So you should, for every patient, just not enough if you do VILI, you also have to, the first one is VIA. And if you also have facilities, you could do both visual inspection with leukocytin also. Now, many studies have shown that the VIA is very, very useful. And finally, people have concluded that it's a very feasible method, especially for low resource countries where you cannot or cannot afford to take a pap smear. That would be better than not doing anything. In fact, in all the rural areas where you don't have a pap smear, because pap smear is little expensive when they don't have that, at least you could do a VIA. In fact, in our OPDs also, we used to have a bottle of acetic acid. So every patient, when put in a speculum, we used to put this acetic acid, and only if this acetic acid is positive, we used to send them either do a pap smear or triage them and then do a colposcopy or a pap smear, whatever was necessary as per protocol. The next one is a pap smear. Initially, we had the conventional pap smear. Now we've moved on to the liquid-based pap smear, which is much better than the conventional. So we don't have any errors in pap smear. The only problem is the pap smear and the VI, the same specificity and the same sensitivity. So it could be used. But however, pap smear has its own disadvantages. But the best test which WHO says is your HPV testing, because now they said the HPV is the cause of cervical cancer. So they've identified that 70% of all cervical cancers are because of HPV. And it's more than HPV testing, it's the presence of the high-risk HPV virus, which is very, very important. So here we have this HPV testing. Now for this HPV testing, many people less than 30 years, at least 70% of the entire population would be suffering from, will be having this HPV. So just the presence of HPV does not mean that the person is going to have the cervical cancer. It's the presence of the HPV high-risk viruses which are important. So when you do the HPV testing, it will tell you whether the particular person is having the high risk, especially 16 and 18 of all the malignancies, cervical malignancies. 70% of the malignancies are caused by 16 and 18. And of course, we have the other types 30, 33, 40, 45. So the test will tell you whether the person is having the HPV high risk. And if the person has a HPV high risk, then you triage accordingly. You will see, are you going to do a pap smear or are you going to do a colposcopy? And if a colposcopy says it is positive, you could do a biopsy. So you triage the patient accordingly to the report. Now this HPV, the problem for testing for all our patients is, once delivery is over, they don't want to come to obstetrician at all. According to them, everybody is fine. They think we will not suffer from anything. In fact, when you go to camps also, everybody says, Madam, I'm perfectly fine. Why should I come for a cap or why should I have an examination? I'm totally asymptomatic. So in such cases, the only other way is to do a self-sampling. So tell the patients about all the, create awareness, tell them what all about cervical cancer, how do you diagnose, how do you prevent it, and then you advise them to do the self-sampling. In fact, we have started a self-sampling method. We're targeting around 10,000 women in Coimbatore, and we're doing the self-sampling method. We're using a pap smear, using a self-sampling. In patients really find it acceptable because they don't want to, they feel so embarrassed to lie down on the couch, and you tell them how to do it, and then they find it much more easier. So in fact, they say that this method is more attractive, especially for the women who are never screened or have a long screening duration. They say this is the method which should be incorporated. Now, so like I said, WHO recommendation says you do a HPV testing. Now, is it cost effective? When you do a HPV testing, it roughly comes to around maybe 3,000, 2,500 rupees to 3,000 rupees. What about pap smear? You can get a pap smear done for less than 1,000 rupees. So when you compare this, is it cost effective? Yes, it is cost effective because you need to do the test only twice in your lifetime. It says you can delay the duration of the test to 5 to 10 years. Whereas we do a pap smear, every 3 years you have to do the pap smear. And this test is more robust than a pap smear. So putting everything together, HPV testing is much more cost effective than the other two tests. And you can do it once in 5 to 10 years. So the WHO recommendation is you do a HPV testing rather than any other method. In fact, that is what Dr. Shankar Narayan also says, HPV testing, we should have this HPV testing. Now, as far as rural India is concerned, what do we have? We have various rural cancer registries. We have a camp approach. We have PHCs which do this HPV testing, which screen for cervical cancer. And we have all these village health nurses who are trained in doing the screening. So let me take up one by one. So rural cancer registries, at least 4 or 5 of them are there in our country, where there are certain centers, and people periodically from those centers, they go around to those villages, identify people with any problems like white discharge or any abdominal bleeding, and then they brought to the center and then they are followed up. So that is again an effective method. The second one is camp. In fact, many of us are very, very familiar with these camps. Generally, we go to some outskirts and then do a camp there. This is a mobile van which is from Pune, where they converted a van into a camp. This has also been done in our part of city. Also, you have an ambulance, like a big van has been converted. You have a cot there, you have a colposcope there. Patients are brought there and then examined, and then do the test there.
Again, a village health nurse can go how to teach them about cervical cancer and then ask them to come to the center to do a screening. And this has been practiced in our centers where non-communicable diseases, 4 diseases are important, and they pay a lot of attention for as far as cancer is concerned. In fact, in all PHs in Tamil Nadu, people have been told to do a pap smear. So whenever they come for any problems, they're advised to take a pap smear for all these patients. Even in real practice, even if that does not happen, at least for people suffering from white discharge or intermenstrual bleeding, etc., pap smears are being taken in PHCs. So in India, we don't have a structured program like what is happening in UK. It's such a large country, but I'm sure if efforts are put in, we can be able to, bring about a structured problem simply because the population is so much. So what are we left with? We are only left with opportunistic screening and by doing camps whenever possible and in PHCs. So what is this opportunistic screening? Whom all are we going to screen? How are we going to screen? And when are we going to screen? Now, before we go to that, I just want to tell you a small little thing which happened 2 days ago. I saw a patient just 2 days ago. Now, this particular person, Mrs. X, was present with 6 months of irregular bleeding. And this particular person has gone to a small clinic where she was given only NSAIDs and she was being set up. She went repeatedly to the particular doctor saying I had irregular bleeding, but nobody bothered to examine her. Just 2 days ago, she went to another doctor in a bigger city. And she put in a speculum and she told her something is abnormal with you, and then she referred the patient to me. This is what we saw. Such a large growth, around 4 to 5 centimeters in size, proliferative growth. So the particular person has been having irregular menstruation for 6 months. We're talking about screening, but like Kamal Bakshi ma'am and all the others who said, it is very, very important that we go back and do our clinical examination. That is very, very important. A simple speculum examination she could have identified the small thing earlier, 6 months earlier, and the patient would have been in the early stage rather than seeing now she's already in stage 2B. It's extended on to the vagina. So could we not have prevented it? So it doesn't require any screening, just a simple examination. And I must acknowledge that many of us don't do this small, simple speculum examination. We should insist that every woman who comes to the OPD should have a clear speculum exam. It might be there in institutions, in corporate hospital, but I think in small centers, for lack of availability of so many speculum or whatever, due to so many other logistic problems, a speculum examination is not being done every time. I think as senior faculty, we should make it a rule. Every woman must have a speculum examination. Okay, so it cannot replace. This should have had an ultrasound, surprisingly, sometimes even an MRI, but a simple speculum would not be done. And I must also say that I had recently had 2 patients who had excessive bleeding per vagina, and very reputed endoscopic surgeons, gynecologists, in fact, they did an MRI and then told the patient you have to have a surgery. I just put in a speculum and all that she had was a huge polyp. Remove the polyp and patient is fine. So everywhere it happens. So just speculum, you could see so many things. Why are we not doing that? I really want to know. We are talking about why we should really talk about simple speculum. Every person must have a speculum. I want this all of or everybody to take this as a important thing and to do it. Okay. And so whom are we going to screen? I think any woman who walks into the gynecopedy after 35 years should be screened for cervical cancer. If she's less than 35 years, you could do a pap smear, especially after sexual activity. And we could also use all women coming to the master health checkups. All women coming to corporate centers whenever they have master health checkup. This should also be included. Breast examination and the pap smear should be included as part of the things which are available. And of course, annual checkup. So whenever possible, every woman, whenever the opportunity we have, we should be able to screen. It could be postnatal also. There's nothing wrong in doing a pap smear for a postnatal woman. This is again a camp that we have. This is about self-sampling. So here the nurse is telling them how to do a self-sampling. Like I said, HPV is the best method. But if we don't have HPV, don't worry. A pap smear is also good. If nothing is there, EVI is better than nothing. At least If nothing is there, at least a speculum examination. So with 4 things: speculum, next would be VIA, then next would be pap smear, and finally we have the robust test, which is a HPV. Now camps, we go to the next part, which is camps. Though we conduct camps, we must realize that conducting a camp is not all easy, because it's very important for us to get the people. And once they come to the camp, once I see them that they have to lie down and exposed, they're not willing. They jumped up from the table and said, I don't want an exam, totally normal, I don't want a camp. So there are very many barriers. So what are the barriers? One is they're scared. Though they think they may not have, they're scared that what if the test is abnormal, they tell me that I have cancer. And they're extremely ignorant about the disease. What is the importance? They don't know what to do because of the illiteracy and extremely unhygienic conditions. So how are we to create this barrier? What are we to do? The most important thing is to create awareness. So we should tell all of them, we should educate them what is the importance of cervical cancer, how it is caused, it is highly preventable. And you should have a person who is already suffering from cervical cancer, talk to them and tell them it is important that you get yourself screened so that you will not be suffering from the disease, change the attitude, and then counseling, dispelling fear. All this is very important. All these are barriers, and we should be able to overcome all these barriers for our camps to be very, very successful. We could go around telling them. So straight away, you can't go for a camp. You have to go for a field visit initially, educate them properly, and then tell them what the entire thing is about, what they have to expect, and you have to treat them and motivate them. That is very, very important. So this again, the study which was conducted, which just assessed what is the knowledge, attitude, and practice, and it showed that the knowledge was very limited. Only 20% of them had any knowledge about CS cervix. The attitude was even less, and the practice was only around 13.5%. Now, in November 17th, there was a call for cancer cervix awareness, and that particular day, the entire city of Coimbatore was green. This is the green that we could get. Many big buildings were illuminated. So once you do this, everybody will be wondering what is wrong, what is they doing this suddenly, and then that will create the, let us go up and look around. What is this special about this particular So this is a diagram which said many cities in our, many institutions in our city were teal color, with this green color. And people ask what is important. So that is one way in which we can prevent awareness. So whenever possible, prevent awareness. Spread awareness. That will tell us what is, and it will help them to find out what is a cancer cervix, how do we prevent it, what all can we do. So whenever we have an opportunity, we should use it to the maximum. So it's important, we should have a structured program. If you want to reach the goal of 90, 70, 90, we should have a structured program. And it's just not enough if we just do screening. It's very, very important that we get these patients back for follow-up. There's no point in doing screening in 10,000 villages. If those people, we don't get them back, we should be able to follow all these individuals. That is very, very important. And again, let's end cervical cancer. This is our, like I was telling you, this is a program that we have taken up from Coimbatore. We have a cancer foundation, and we have decided to do 10,000 women, all by self-sampling. So every place could be doing whatever they want. So we can end this problem of cervical cancer together. All of us could end. So this is the aim of WHO, to bring down the incidence to 4 by 10,000. When will we achieve? By 10 years, is it possible to achieve? Study says it may not be possible, but I'm sure if all of us join together and try to do a structured program, we will be able to achieve. If not by 2030, at least by 2040. They set the SDG goals for maternal mortality, and haven't we achieved? The same thing we should be able to achieve if all of us join hands. So thank you so much for giving me this opportunity, and for your patient listening. I would also like to make a small appeal. I'm contesting for medical disorders in pregnancy, so I kindly request all of you all to support me. Thank you very much.
All the best.
Thank you, ma'am.
All the best.
Thank you so much, ma'am, for such a wonderful talk. With such, we have good targets, and we need like a great effort from all of us, gynecologists, like preventive gynecological oncologists, to achieve this target.
I'm sure we will achieve it by 2030, if not a few years later. So I would like to invite our chairperson, Dr. Geeta Gui ma'am, to give to conclude this
Dr. Kiran
talk.
will conclude. Dr.
Okay,
Kiran will
ma'am.
conclude.
Okay.
Dr.
Dr.
Geeta is
Kiran
not
ma'am.
there.
Dr. Geeta is not here. Yes. So Kiran ma'am, kindly conclude.
Hello. Well, thank you very much. It was Dr. Chitra has very comprehensively covered from the screening, started from the basics to the end, and really she has told the importance of screening. That is the significant thing. We should all focus on that, because this is one cancer, as I also said. Am I audible? I think so. I'm audible?
Yes.
Yeah.
Yes,
So
ma'am. Yes,
I
ma'am.
also said it in the beginning, and Dr. Chitra also emphasized about it, that this is one cancer which is preventable. And unfortunately, even after that, we are not able to do so. It is still the second most common cause of death of the women from the genital cancers in India. So that is we should all focus on more screening methods. In fact, I don't know if you have, Dr. Sadhana, you must be having some idea that I have been doing work on the optical fluorescence with the IIT people. We have done a lot of work, which is from 2008, and we have found that if we have made a probe, handheld probe, just like a post, just like a cryocottery machine, something like that, and if it has come into the phase 3, so if it works, it might turn out to be a very important thing, where even the rural people, as Dr. Chitra was emphasizing, the projects for rural India, it can work, that even those ANM, we can train those ANMs and ASHAs into this, which is a very simple thing. So that, the mass screening is most important, because at the moment we are doing basically opportunistic. The patient who comes to the hospital, we obviously do pap smear and whatever, colposcopy and everything, but otherwise not. So that is the, I think, the most important thing on which we should focus.
Thank you.
I would also like to request each and everyone who is here that I'm also contesting for Medical Education Committee. So please, with folded hands, I can say I'm holding the phone, so I can't fold my hands, but you can understand that I have those folded hands, and I'm requesting, please nominate my name for Medical Education Committee chairperson. Even I would request Dr. Chitra also that we can mutually contact. And also the most important person for all of us is Dr. Sadhana, because if she comes, so then we have that, some effect. If so, we know that we would like to have our leader to be there with us.
Yes.
All the best, ma'am, and you need not fold hands, ma'am.
Thank you.
All the best.
Thank you, Dr. Amrita. Thank you.
Thank you so much, ma'am. Best wishes for your.
Thank you.
And we are all with you. Yes, with all your hard works, ma'am, I'm sure you will achieve your goal. Again, our best wishes.
Yeah, teaching is my passion. That is why the Medical Education Committee is most important for me.
Okay, ma'am. So our next speaker is a very, very dynamic lady. Listening to her is always a pleasure, because she begins with the basics and ends with the basics. Our own Dr. Sadhana Gupta ma'am, and to invite her for this talk, I would like to invite, I would ask Dr. Archana Kumari to do this honors. Kindly introduce Dr. Sadhana Gupta ma'am for her talk.
Thank you, Dr. Babita. Nothing could have been more rewarding than giving me the opportunity to introduce Sadhana Gupta ma'am. She is a well-known personality all over India. But of course, the I would like to introduce her formally. She is the Director and Senior Consultant OBGYN at Jeevan Jyoti Hospital Medical Research Center. She is Founder Trustee Jeevan Jyoti Trust, Gorakhpur, UP. Ma'am was the FOXI representative to CEPFOG in 2018-20, Vice President FOXI in 2016, ICOG Governing Council member in 2015-2020, corresponding editor of OBGY between 2017 to 2020, Chairperson Safe Motherhood Committee 2011 to 2014. And I remember during this period, she had come to Ranchi and we had a very wonderful panel on PPH. I don't know whether Madam remembers it or not, but I remember it.
Ranchi visits always.
He is the FOXI representative to WHO UFPA workshops on prenatal RCH in 2013. Well, Madam had so many accolades and so many publications and achievements. So, and Madam has been the sole author of Cesarean Delivery and a Vaginal Delivery, a comprehensive textbook of OBGYN. I would definitely like to have a copy of this for my postgraduates as well. So, Madam, I welcome you and the floor is yours.
Thank you, Dr. Archana. And again, my all regards to our dignitaries, all faculties and all people, viewers who are with us pan-India and across India. So with a wonderful talk by Dr. T.V. Chitra, which is one of the most like a sword in our country that we have still contributing to a lot of cancer burden. And we are coming to the second cancer and where we are, which is not that common, which is neither, it is my screen visible, which is neither not common and it is not rare also. So we all know when we we see a 65, 70-year-old woman and we find a ovarian cyst with multi-septate solid. And this is a question which comes to me like, oh, at this age, that much of suffering and whatnot. So we are here and I bring greetings from Gorakhpur, and what we say that is the wiseness is not in the seeing, but it is on the seeing well. That is observation what Dr. Kamal Bakshi says, what all guests of honor and Dr. T.V. Chitra emphasize. Just let me just a minute. So Buddha and Gorakhnath, it is the where the city we represent, and they emphasize on seeing wisely. So philosophy is not like away from the science. And ovary, what is special about ovary? Ovary possess a mysterious physiology, affect all organ from head to toe, and it is for the vigilant clinician to decide that they want me as a friend or foe. And next 15 to 20 minutes, I will take that all clinicians have a friendly relationship with the ovary and the screening for ovarian cancer as well. So ovaries are mysterious, and like what nature and the God has decided that every reproductive organ, it is concealed. It is like concealed because it needs protection. So mystery lies that the ovary has got relationship with every cell of the body, like from the pituitary hypothalamic axis to body fat and everything. So it is not only the reproductive organ, it has a intricate relationships at multiple levels. And ovaries, second point is that ovary is inaccessible. So like what was the positive point in the cervical cancer screening, that we can see it if we want to see it, but we cannot see the ovary because it is inaccessible as it is designed by nature. And that's why we always have a delay in ovarian cancer diagnosis. It may be borderline tumor or it may be frank ovarian malignancy. So what I say that neither it is a common and it is not uncommon, so that the science is confused that what to do. Still, we have around 250,000 people who are suffering from ovarian cancer, and mind it, this is important, that around 50% have the mortality. Fortunately, in Asia, we have less incidence as compared to developed world. for the ovarian cancer. But because we are contributing to 1.3 billion population, so actual burden is quite high. And ovarian cancer is on the rise, and right so, because the life expectancy is increasing and age standardized incidence is increased by 28.6% in the last decade. So it is one of the most lethal malignancy. 5-year survival rate if woman is diagnosed at advanced stage, it is around 20 to 30%. But if we diagnose ovarian cancer in the initial stage, that is stage 1, the survival rate is 70 to 90%. So there is a close correlation between stage where the patient present and the survival rate. And it sets the stage that can we do early detection of ovarian cancer, and can we have any screening protocol for it. It is the simple FIGO classification staging for the ovarian cancer. It is 1 ovary, 2 ovary, and the pelvis, it is 2. When it is outside, it is a retroperitoneal, it is stage 3, and stage 4 when it is a distant metastasis. Again, what we say that if we diagnose the ovarian cancer at late stage, we are not able to save that woman. Mortality rate can be improved through prevention, screening, early detection, and optimal management. This is the question, and mind it, question is not that simple. If the cervical cancer and the breast cancer screening have their own issue, then the ovarian cancer, by its presentation, by its nature, sets more question to us. So what is the thing? It is examination. In ovarian cancer, it is talking. We don't want we think that we don't use the word cancer. It is just a health screening. It is a checkup for health. It is not checkup for the cancer. So talk the patient whether patient's first relative, second relative have any history of breast cancer, ovarian cancer, endometrial cancer, and colon cancer. That sets the stage for many screening points in ovarian cancer, because 10 to 15% of ovarian cancer occur in the gene mutation. Obesity, it is worldwide on the rise. In India, it is on the sharp rise, and that contribute to every cancer. It is endometrial, it is breast, and it is ovarian also. Nulliparity, somehow women are like designed to produce the child, and every additional birth actually reduce ovarian cancer by 6%. And when the people are having childbearing at a very late age and very small family, that may be cause of rise of ovarian cancer in last 2 decades. Tobacco smoking and use of postmenopausal hormone therapy. So this is another important point, that we should be very judicious for the postmenopausal hormone therapy. Shortest, safest, and well indicated, because it is again a contributor to ovarian as well as the breast cancer. So what is the protecting thing? You see the patient fully. You don't see only the ultrasound, which is actually has become a very good technology, is being like abused, because the gynecologist clinician has become lazy and they don't want to see the patient as a whole. So nulliparity, early menarche, late menopause, increasing age, they are associated with increased risk, but the protective factor, that is the use of COC, pregnancy, lactation, and tubal ligation, are associated with reduced risk, and we must be aware of it, that what can cause more chances of ovarian cancer and what are the protective factors. Now coming with this background, what is the screening and preventive strategy? Now, when we talk of screening, we must know what are the criteria of screening in today's science. It should be inexpensive, easy to do, minimal discomfort to patient, consistently reliable, valid, highly sensitive and specific, and screening program should be focused to that population which can have that disease. And when we do any organized or informal screening test, we must show that there is an improvement in morbidity and mortality. What Western world has shown, that the regular pap smear has actually reduced the morbidity and mortality much before the HPV vaccination. So this is important, but unfortunately for screening of ovarian cancer, we don't see even on a horizon that good screening test. So what we are left with? Why it is so? Because it is different, because it is sporadic, it is neither common nor rare. So hereditary, talking to the patient about the history, even a male breast cancer history, in a male colon history, this is very important because 90% of BRCA gene account with the 10, like 90% of the epithelial tumor can be somehow related to the genes, and the cumulative lifetime risk of ovarian cancer from BRCA1 is 50% around, for BRCA2 20 to 30%, and for HNPCC it is 12%. So in a clinical history, we should be aware that this should be part of our routine history taking, especially when we are dealing with the any elder or the post-menopausal woman. So this is the risk assessment, and again, risk assessment, it is depending upon the genetic history, what is happening, and then on the BRCA1 and BRCA2 mutation. What are the challenge of screening for general population? Because it should have a minimum positive predictive value of 10%. It is generally, what is the issue that when we do it is a positive screening test, then for confirmation of diagnosis, we need surgery. And that surgery has got its own issue and in own complication. Second thing, like CA cervix, we don't know that what is the predisposing factor, what are the histological precursor lesion or molecular event. We also don't know that what is the time required from stage 1 to stage 3, because suddenly we come and we see ascites and the bilateral tumor, and we actually, like 6 months ago, patient might be totally well. Most biomarkers which we evaluate in routine clinical diagnosis, they have been tested in a high risk population or in the cancer patient. So we actually don't know that in a low risk asymptomatic woman, what are the value of normal biomarker. And again, it is a low prevalence, it is not that common. So we need a very, very large prospective cohort that this test is useful or not. Again, an important message I want to give to all people, that we have to differentiate as a clinician between type 1 and type 2 cancer. Because type 1, which is fortunately more common in our country, India and South Asia, has an indolent nature and a better prognosis. So this basic should be like clear. We should be very clear that type 1 is indolent as compared to type 2, which is aggressive. We have got more genetic instability in type 2, and in type 2, that origin is considered in many cases the ampullary region and the fimbrial region of the tube, while for the tube type 1 we have the endometrioid, clear cell, mucinous. So when we see endometriosis, then it is suddenly change in the texture in the ultrasound, and sometimes you get a high CA125, more than 300 or 250 level in premenopausal. So we have a time to say, and the precursor as benign cyst. And fortunately, we are having more incidence of type 1 cancer as compared to type 2, which is more prevalent in the Western solution. So challenge with this challenge and solution, what we do, again, what we are left behind, these are the 3 things which has been tried all over the world. That is a complete gynecological examination. And a second thing beside history, I want to communicate that any woman, especially in our elderly people, if she says again recurrent abdominal pain, gaseous distension, less of appetite, feeling full, bloating, don't take it as like a menopausal thing or something psychological, because the patient speaks. Actually, her symptoms speak. And when we pay attention to these symptoms and get on her other examination to confirm or exclude it, it will really have a role in the early detection of the cancer. So it is a silent killer, what I say. So listen to the patient for these vague symptoms. Now, these are the 2 or 3 very, very big trials, that is UPSTF and Blacotire, and I will go to the details what they have come out. The second thing after clinical examination and history is the CA125. And CA125, it again, I want to emphasize that it is the low positive value in the premenopausal woman can be deceptive. And if it is in postmenopausal, it is more than 35, it is important. But in premenopausal, we can have high CA125 value in many situations like tuberculosis, like endometriosis, like fibroid, many benign conditions. So where the today world has come, that CA125, it is important, but it becomes more important when we do the serial CA125 examination. So that has been included because single cutoff value has not been found effective as a screening tool. But if we do the repeat examination and there is a rise of CA125, then it can be a good screening tool. Beside only epithelial tumor have got the CA125 high level, beta HCG, AFP and LDH for the dysgerminoma, for the germ cell tumor. And we must be aware, so many times clinicians write only CA125, but we have to be careful that these, like even in the adolescent age, where the adolescent malignancy or the pediatric malignancy, we have a different type of tumor and CA125 is not going to help. So this is about basic and the ultrasound. Now, many studies, we will just go to the next research topic, but ultrasound is a very good tool. And when we do transvaginal ultrasound, we can have very fine detailed image of the ovary. And sensitivity of transvaginal ultrasound is around 85% with specificity 98.7% and positive predictive value of 40%. Important thing we can take in premenopausal women, it is more than 20 cc ovarian volume, and in postmenopausal more than 10 cc cube. So this is important, and question is that there is a lot of intra-observer variation, and that has got one ultrasonologist right, it is a complex cyst, and they don't like follow any protocol for reporting it. So IOTA, that is IOTA and the RMI index, this should be on our table, on table of ultrasonologists. These are very well-defined things. And in IOTA, it is very simple. And if you have got any one malignant rule, that is irregular solid tumor, ascites, 4 papillary structure, irregular multilocular solid tumor, and the good vascular flow. If there is any one malignant rule, then you should refer the patient to the gynae oncologist. Likewise, RMI also say it is solid, it is bilateral, it is ascites, it is metastasis. So we have to be very meticulous in reporting. We may know many things, we may cram and we may project, but if the things are not to be used meticulously and in a coordinated way in our clinical practice, we are going to have the patient always with the advanced cancers. So it is a annual examination. Please mute everybody. Annual examination, CA125 and ultrasound where we are. With this knowledge, what our screening methodology, please mute, Mashish, kindly mute everybody. So what is the research and evidence which actually causes more questions than answers? So these are the 3 tools, and it is the, I will share few trials which are very important for the human and the woman and the obstetrician and gynecologist. It is a Pleco trial on 78,237 healthy women between 54 to 5 to 74 years, and it shows that actually when we do, Mashish, kindly mute everybody, which shows that the screening effort did not change the expected stage of distribution from unscreened population. This is UPSTF trial which is done on a large number of women, and it again shows when we do screening for a low risk asymptomatic woman, actually we didn't have any mortality benefit, and we did have quite a good number of false positive screening tests. It is UK CTO's trial, which is the recent around 2 lakh postmenopausal women. And it shows that if we do the repeat screening, like not a single value, but if we do the repeat screening of CA125, it may reduce some mortality related to ovarian cancer. So low risk asymptomatic women, it is UPSTF, UKPSTF, and it is done in the UK and the USA, and the multi-centric studies and the multinational studies. And what was the important thing, which is very interesting, that when we do a screening test in low risk population, there was a false positive rate in different groups. only examination, only CA-125 and CA-125 and ultrasound. And when we have that much of 0.2 to 3.1% of positivity, and to confirm that screening test, the surgery was done and ovary was removed. And out of this, 15% of women who are negative, but they had the major surgical complication. So in ovarian cancer, screening to be taken very, very carefully, because we need further surgery to confirm it. And many times the negative women also have got the surgical related complication. So that's why it is important. It is cost effective or not. So it is says that it is not considered cost effective. And the most important thing is that if we do screening in low risk asymptomatic women, it can do sometimes the potential harm due to the invasive surgery. But in high risk women, what I say that we say that the patient who have got the family history, who have the many and encouraging factor for ovarian cancer, like smoking, small child, obesity, these are the patients which require the screening modalities based on annual examination or CA-125 and the transvaginal ultrasound examination. So this is very important. And ACOG and many society, after a vigorous study on millions of women, says that we are not still ready to do the screening for all post-menopausal women, all low-risk patient, but in high-risk patient, we should consider it. Because, you know, it is one thing that whatever research says, and it is put on the page, but we have to question. And I think any obstetrician, clinician, or any family who have undergone the tragedy and the treatment and the chemo and the surgery extensive for ovarian cancer, they have put the question that disease is so aggressive that we must have some screening protocol. And they responded back very respectfully that we are not considering cost of screening, we are not considering cost, but actually it has not been found beneficial for very low risk patient. So again, we have to be very careful that what patient we have to do the regular screening and what patient we have to do the focused screening. So it is ACOG, American Cancer Society, American Academy of Physicians, and the National Comprehensive Cancer Network. They say that for the low risk, it is different protocol, but for a patient with the family history or the risk factor, we should have the different protocol. Last word about the high risk women, that is the genetic, who have the genetic predisposition. We are not able to do the BRCA gene mutation for many part of our women because it is a costly, not so easily available also. But we must take the history because hereditary predisposition accounts for at least 10% of all epithelial cancer. So this patient, one message which I want to give, that if the patient has genetic susceptibility, we should do BRCA1 and BRCA2 because it is the technology actually which can transform our life, because these patients really require a clear framework. What is their probability of having ovarian cancer? And when they are having BRCA1 mutation, it is considered that they should do the annual all three investigation examination for the screening between 30 to 35 year age. And once they complete the family, they should undergo the risk reduction salpingo-oophorectomy. So message is quite different with the women which are having the BRCA1, BRCA2 mutation. And we must be very careful in picking up those women. So risk of ovarian cancer after hysterectomy, when we don't remove ovary, it is 0.1 to 0.75%. The another thing is the opportunistic salpingectomy at time of hysterectomy, because especially the type 2 ovarian cancer, the origin is the femoral end of fallopian tube. So when we are doing any cesarean section, can we do it if the patient has completed family? So this is very important. If the patient is having a high risk factor for many things or for genetic predisposition, for the other things, then we can do this opportunistic salpingectomy. But it is said again that we just to do opportunistic self-injectomy. We should not change the plan of in what ways we are doing the hysterectomy. So many research are going on. Still, we are not having a very good screening tool, but these are the 3 tools which we have to focus. Lastly, a word about what is the prevention study, what our guest of honor and the chief guest said, that it is a primary prevention. And in South Asia, we are fortunate that the women don't smoke, women don't take alcohol that much. It is on the way. It is supposed to be one of the symbol of women empowerment, but I think it is something nexus which are keeping these views. So quitting smoking, alcoholing, maintaining good body weight with a good diet. The India is a country where we are fortunate to have the maximum biodiversity, fresh fruit, vegetable, and there is no way why we should use packaged food or any like a more fat in our diet. We should be hardworking like we have been, and the occupational safety and vitamin D supplementation. If the woman is deficient, it has got also some effect on the invasive behavior of epithelial ovarian cancer. So what we have positivity in our country, that initially we are proposed less incidence of ovarian cancer, then we have the more incidence of type 1 cancer. Then we should, like, what is our breastfeeding, like completing childbearing at the right age, and they should the all protective factor for the ovarian cancer. So it is the thing which we can do as a clinician. Future direction, always we are futuristic. We have understood role of fallopian tube and the bilateral salpingo-oophorectomy as a risk reduction strategy. A lot of genetic technology with all, like the future medicine is either preventive and it is on the genes. So many research are going on. SNA, so many overexpression, genetic expression, and it is again like it is emphasizing the role of genetics in the ovarian cancer screening and the early detection. Vaccine, it is COVID vaccine, and we are suddenly very much sensitive population to vaccine, and mucin core protein that is expressed in most breast cancer also have been proposed as preventive agent, and the work is going on that this MUC1 mucin core protein, which can be used as a vaccination against breast cancer as well as the ovarian cancer. So 21st century sees prevention as a best cure, and all sustainable development goal aims for equity, equality, accessibility in healthcare as well as life. So it is like our professional bodies, like we should have first the equity and equality, and we should have that, what Dr. Chitra said beautifully, that rural population, what we can do, like don't like overlook them. Don't blame them for their poor health status or their health problem, because everybody is product of their surrounding, and it is a disparity, because high-tech medicine is like considered, it is a question mark because it is too costly, it is too complex, and it is for elite person. And as a obstetrician and gynecologist, as a clinician, actually we can make the technology as well as knowledge too cheap also, accessible also, and user friendly also. So we have to be very careful that, like we know COVID, no, if everyone is unsafe, then everybody is unsafe. So we have to respond to the challenges which our experience have put before us. Thank you very much for joining journey, and we look forward to many future leaders from everywhere and for everywhere. So I also request for your crystal clear, democratic, dedicated choice for Foxy President, and let's work together, and let's work for women health, for all, for by everyone. Thank you very much.
Thank you, ma'am, for such a comprehensive talk, as usual with basics. Very crystal clear.
I think it is not basic only, it is basic to futuristic. So,
yes, ma'am.
Yes, ma'am.
Yes, ma'am. I would just like to.
Yes,
I would like to just give some remarks
to give the concluding remarks on this talk.
Yes, this was a wonderful and very informative talk with very clear-cut take-home messages. Madam started with the very basic point that our clinical acumen should not replace just the ultrasound. People always come, the women come with ultrasound report, and I have seen even the postgraduates directly looking to the ultrasound without doing clinical examination. We should not miss this part of doing a basic clinical examination, right? Like Dr. Chitra ma'am also said, in case of cervical cancer, a simple speculum examination can detect so many cases. So here also we should first do a clinical examination, and then Madam told about all the screening methodology like transvaginal sonography, the role of tumor markers. She discussed extensively about various clinical trials and the future areas of research, and definitely she highlighted the role of doing a opportunistic hysterectomy at the time of opportunistic salpingectomy at the time of hysterectomy, and whenever possible, if you are doing a concurrent sterilization procedure in a woman undergoing cesarean, we might think for doing a bilateral salpingectomy, especially in women with who are at high risk of developing ovarian cancer, like those who are having a family history. So thank you so much, ma'am, for giving me this opportunity, and all the best to all the contestants, Sadhana ma'am, Chitra ma'am, and Kiran Pandey ma'am.
Dr. Kiran, you want to say something about it? Like you have been quite active in oncology, so we will really like, because it is a picture where we have to be a little different. So Dr. Kiran, any comment from your side?
First of all, so I would say, Dr. Sadhana, it was a very informative talk. You have, presented so many trials. In fact, I have also not gone through those trials. But the basic message which I would say, which has come out from it, that we have to focus on all us preventive aspect. Obviously, that is the best thing. If we can prevent, you have told all these strategies for prevention. At the same time, you have taken us to the futuristic, the medicine, and that also aspect, which is, for which we have to, academicians at least have to hope that something comes out. The screening dilemma is also a very strategy which you discussed, is a very important thing, because even now we don't have any standardized, recommendations for screening. And many a times we are losing patients just because we don't, in MBBS also we were told that it is a silent killer, and actually it is a silent killer, because the symptoms which do come out, that symptom complex also which has come out, it is still vague. Like GIT systems more and more. So it is more of that we have to keep a high index of suspicion, is a very important time when the patient comes to us. Now we have to spend at least 5 minutes dedicated to her history, in which the family history is very important to be understood, because once it is understood, definitely we'll try in those investigations to be done. So then examination, and then the imaging modalities have a very important role, because the person who's doing ultrasound itself is a very good imaging, I would say. If one has to look for those iota, the B rules and M rules, and if your ultrasonologist is giving all those information, if not giving, gynecologist should be particular to ask those informations, I would say. You should specifically ask for it. It is a unilocular, multilocular, thick walled, papillae, solid, hemorrhage. These things, and putting the color also, because though it's not the only thing, but of course the flow of, if the blood flow is there, definitely it has to be carefully looked at. So even though screening is not there, so we can only screen it by the symptoms and by the history and by keeping a high index of suspicion. These days, even young patients we are having, lots of young ladies are coming with the ovarian cancer. And we all know okay, once it is there, how much, I mean, chemotherapy and whatever you do, still the prognosis and the mortality is not so good as, I mean, like the cancer which we discussed before, this cervical cancer, where it is almost preventable. And we have a very good result. In the ovarian cancer, we are never sure what type of result and we can't tell the patient. And even if chemotherapy, the newer chemotherapies have come, but they are very costly. So that aspect also matters. So we should focus on these things, spend little bit of time, keep always, if there is adnexal mass, please look carefully, evaluate. The biomarkers are not very helpful, in fact, imaging more. You all know that the self-injectomy, as Dr. Sadhna said, the opportunistic self-injectomy helps a lot. But besides that, it can also have a origin from coelomic epithelium also. It can, I mean, like it has either from the self-pings or from the coelomic epithelium or the ovarian. So any place from which it can arise. So we should all keep these things into mind. That's what I personally feel.
Sadhna ji, can I say something? Hello.
You're welcome, ma'am. Sure.
Just two little things I would like to say, which I find helpful in my practice. Number one is in history taking leading questions. If we don't poke them regarding the malignancy in the family, sometimes patients do not volunteer it. So we have to ask कि घर में किसी को भी, कोई भी औरत को कोई कैंसर पहले हुआ है जो आपसे ब्लड से रिलेटेड है? Very clearly I ask them. And sometimes then only they will say yes, whether they had some breast cancer, or they cannot specify whether cervical or uterine, but they'll say कि कुछ हुआ था कोठी का cancer sometime. But just on their own, sometimes they never volunteer this. And number two, in my practice, though not going for all those molecular and all those CA-125, we all do. And we all do 2 or 3 to check if we are observing a mass, adnexal mass. But this colored Doppler I find is very helpful. If the vascularity is increased, that gives a very good index of suspicion to me. And quite a few times early ovarian mass or early ovarian tumors I have detected. So these are only two little things I wanted to say from clinician's point of view.
Thank you so much, ma'am, for such useful tips. Now we come to the end of our session 1, and I hand over the virtual dais to Dr. Aruna Chaparia for conducting the second clinical session.
Thank you, Dr. Babita. With the blessings of our dignitaries and seniors,
Aruna?
Freeze हो गया. Babita, you can like na take over. मुझे लग रहा है freeze हो गया. हाँ, please go ahead with that. Unmute yourself, Babita, and go ahead.
So we carrying forward our scientific session. Second session deals with again 2 very important topics: screening for endometrial cancer, updated recommendation, and role of gynecologists in preventing an early diagnosis of breast cancer. For this, I would like to invite our esteemed chairpersons, Dr. Bharti Mishra. Madam is Professor, Department of Obs and Gynae, MKCG MCH Berhampur. She is endoscopist, FICOG, past President GOGS, ex-HOD, MKCG MCH and PRM MCH, life member of FOXY, ISOPARB, IMS, IH, PCOS, examiner of PG and UG, and has publications in various national and international journals and contributed to chapters in books. She is recipient of awards, Foxian Award and Swayam Siddha Award, and has a vast experience and has passion for teaching, plantation, and providing high-tech treatment to the underprivileged. A warm welcome to Dr. Bharti Mishra, ma'am. Our next chairperson, Dr. Bharati Rajsekhar, Madam is Medical Director, Ops and Gynae Consultant, Vatsalya Hospital, Hassan. She is Honorary Secretary General, KSOGA, and State Vice President of KPMEA. She has been past President and Secretary of Hassan Ops and Gynae Society and Foxy Food Medical Equipment and Drug Committee member, recipient of award, and has been faculty in various state and national conferences. She is actively involved in adolescent health awareness activities and has special interest in adolescent health and high-risk pregnancy. A warm welcome to Dr. Bharati Rajsekhar, ma'am. And again, it is my pleasure to introduce our third esteemed chairperson, our very own Dr. Reena Srivastav, madam. She is ex-professor and HOD, BRD Medical College, President UP Chapter of Ops and Gynae, and President Gorakhpur Menopause Society. She has established the Indian Menopause Society in Gorakhpur in November 2016. Ma'am has organized various conferences from the Gorakhpur Society, be it UPCOG, UFOXC, SAFOG, and she has held almost every important position. Okay, ma'am. Warm welcome to you, ma'am. And now I would request Dr. Bharti Mishra, ma'am, to introduce our first speaker of the session, Dr. Anjana Chauhan, who will be talking on screening of endometrial cancer, updated recommendation. Welcome, Dr. Bharti Mishra, ma'am. Ma'am, please introduce our speaker.
I think her connection is lost.
Okay. So,
Dr. Bharti, I can see her in this thing. Dr. Bharti, are you there?
Am I audible now?
No.
Yes.
Now you are audible.
Now some connection problem was there.
So I think
So
Dr.
Arna has
Bharti
introduced the speaker. Just invite Dr. Bharti ma'am to introduce our speaker.
Fine.
Dr. Bharti Rajsekhar is second.
Can I please have the CV?
Yes.
Thank you. At the outset, hearty congratulations to Dr. Sadhana Gupta and team for having this wonderful webinar on every gynecologist needs to be an oncologist. I think that's what we need to do. Focus more on preventive oncology. And now, without wasting much time, I am privileged to introduce Dr. Anjana Chauhan. She is a consultant gynae cancer surgeon from Ahmedabad. She is the ex-professor of GCRI from Ahmedabad, the president of the Ahmedabad Menopause Society, and committee members of AGOI and AOGS, and various other societies like the IMA and the IMS. She has received numerous awards. To note a few, the Best Paper Award for Mumbai, the Dr. T.B. Patel Young Research Scientist Award, and she's published more than 30 papers in national and international journals, and her special interest is awareness of women, cancers, and prevention. Over to you, Dr. Anjana. The screen is yours.
Thank you, madam, for such a wonderful words. And on the outset, I just want to thank Gorakhpur Society, ISOPARB. I want to thank especially Dr. Sadhana. It was wonderful to listen to your elaborate, extensive lecture. And I want to thank Dr. Amrita, the secretary, for inviting me, and all the eminent dignitaries. I feel so small among you all, huge people in the gathering. And I am an odd person down. I am a gynec oncologist, and to talk about this subject, which is very close to my heart. Endometrial cancer screening, when Dr. Sadhana Gupta gave me this topic, now it becomes a nightmare for an oncologist because we always treat a stamped case. So when such topics are given to us, it becomes a nightmare, and really, it really helped me. Endometrial cancer screening, you know what the fact is. If you look into the consensus, there is no guidelines anywhere. There are certain guidelines for certain categories, and the gynecologists are mostly confused because of the technologies used in the diagnosis and to interpret and to diagnose and further management. So these are the gap holes in the diagnosis of endometrial screening. And I'll be talking today about the screening methods and updated recommendations. We all know it is rise, and the main reason for is sedentary lifestyle is the main cause, and second is the obesity. Obesity is the second most killer disease which is occurring in the worldwide. So this is the reason why endometrial cancer has risen. In India, it is the third most common female malignancy. Or say it is a good cancer because it is diagnosed early because of the symptoms, and if stage 1 and stage 2 well differentiated cancer, they are mostly 98% cure rate. So they are very good cancers. I tell my patient never come back to see me because they're that good. Probably women die not because of the cancer, because of the comorbid conditions. Now, these are the high risk factors for endometrial cancer. I'm not highlighting the high risk factor. I am just highlighting any women coming with such type of characteristic. Think of endometrial cancer, think of evaluation of endometrium, annuliparous, late menopause, obesity, diabetes, hypertension. We know they are hyperestrogenic and they cause endometrial cancer. Tamoxifen, breast cancer patient, high risk for developing cancers, you have to evaluate. Unopposed estrogen, this is the area which I want to highlight because PCOD is too much in rise. 5 out of 6, I'll say 6 out of 10 girls are now PCOD. I have seen endometrial cancer in 22-year PCOD girl. So any woman of PCOD coming in your clinic, think of endometrium evaluation. We advise them for weight management, we advise them for hirsutism, we advise them for diabetes, but we forget about the endometrium. Advise them that these women are likely to develop cancers. They have to complete their childbearing, early marriage, early childbearing. It's protective for them. Second is IVF treatment. Our patients jump from one IVF clinic to other IVF clinic. They never reveal their history. I have seen patients, endometrial cancer patients, if you tell 15 IVF cycles. And clomiphene citrate is no more considered as an IVF cycle treatment. These tablets are given by physicians also. So it is very important to evaluate. A 40-year female walking in my OPD, she had hyperplasia and atypical hyperplasia. We took a history, she had 6-9 cycles of IVF. So we have to evaluate for cancer. So it's very important we look into all these characteristics. Second is, which been talked by my previous speaker, Lean syndrome. It is a genetic disorder. A women having Lean syndrome, this is the only cancer, only category of women where endometrial screening is justified. 5% of colorectal cancer, it is seen that have a Lean syndrome. There's a mutation in DNA repair. Lifetime risk for developing colorectal cancer is as high 80%. These women are continuously under screening. They have to go for colonoscopy every 6 monthly. Endometrial cancer, you see 50%. So these are the women, you have to pick them up and do endometrial screening. Ovarian cancer and GI cancers. Endometrial evaluation in women who is taking HRT is also necessary. You have to every yearly screen them for endometrial cancer or hyperplasias. Any postmenopausal woman on hormone therapy for more than 6 months with persistent uterine bleeding, you have to evaluate for cancer. Any previously anomeric woman on hormone therapy and again have started bleeding, then you have to evaluate for endometrial cancers. Now this I have again justified for screening. I just don't want to say that this is a category. I say this is the high risk group where you have to screen for endometrium, because we are not going to do a generalized screening for each and every post-menopause women. These are the patients, when they come to your OPD, you have to think of endometrial cancer and you have to evaluate their endometrium. Women having exogenous estrogen, women on HRT, PCOD, we have talked about, granulosa cell tumor, delayed period, family history of cancer, any women having postmenopausal bleeding and TVS shows more than 4 mm endometrial thickness, then she has to be evaluated for endometrial cancer. Now I put the slide not to just to discuss, but to see there is no age bar. I've seen cancers from the age of 22, 24, 30, 35. Any women of abnormal vaginal bleeding should be evaluated. Postmenopausal, it is mandatory. You have to evaluate for endometrial cancer. Now this category of patients here, we don't evaluate, we have to exclude. Up till now, high-risk women, we have to include or we have to find out if they having cancer. But in this women, we have to prove them, they have exclude endometrial cancers, women with postmenopausal bleeding, women with pyometria, women with abnormal endometrial cells in the pap smear, perimenopausal women with menorrhagia, or perimenopausal women with an ovulation cycle. So these are the women where endometrial cancer should be excluded. Now screening, we don't have a standard screening method. Mass screening is not advisable. No OPD method is available. Indirect sampling is like pap smear, 50% positivity is there. And direct sampling is endometrial aspiration, which can be done with OPD, fractional DNC, and hysteroscopy, guided biopsies. Endometrial cells are rarely seen in the pap smear, and if you see them, a postmenopause woman not on hormone treatment having endometrial glandular or stromal cells in the cervical smear is a grievous significance and warrants further investigations. Whenever a pap smear shows endometrial cells which are normal in reproductive age, think of endometrial hyperplasia, polyps, or you have taken a pap smear near to her period, then she may be having endometrial cells. But you have to think about and you have to evaluate for all these conditions. Endometrial cells in perimenopausal woman, 4% may have hyperplasia, 2% will have malignancy. In postmenopause, 13% will have hyperplasia and 5% will have endometrial malignancy. And when there are abnormal endometrial cells in a postmenopausal woman, 25% will have malignancy. So you need to evaluate this woman, you need to investigate this woman further. Now coming to endometrial evaluation, the diagnostics tools are ultrasonography, which is a gold standard, hydrosonography, that is for endometrial evaluation and diagnosis, and then endometrial biopsies. Endometrial evaluation, TVS, is the gold standard method, and I take a privilege for the gynecologists. I think they are much better in evaluating endometrium than radiologists, and they can not only identify, but they can even say the pathology. This is the good way of reporting by the gynecologist than the radiologist. Saline infusion sonography, which is not common in our country, but in Western country, it is the very good technique or method. Now looking into the endometrial thickness, it is measured from the myometrial and endometrial junction from anterior and the posterior wall, and it is the matter. This is the thickness of the endometrium. Identification and measurement of endometrial echo and description of the echogenicity and heterogeneity of endometrium are the key defining the endometrial health. Transvaginal ultrasound has a good correlation with the pathological endometrial findings. Using endometrial thickness from myometrium to myometrium of 5 mm considered the upper limit of the normal. Sensitivity is 97% and specificity is 96%. Although the test is very specific, it isn't sensitive. Many women without endometrial cancer will have may have thickness more than 5 mm or more. So it is a more specific rather than sensitive. In reproductive age groups, we see a triple line endometrium, and in menopause, it is a thin line endometrium. The cutoff value, whether to consider 4 is mm, but to cut off threshold value to consider 3 mm or 5 mm is a point of consideration. Cutoff of 3 mm is less likely to miss a cancer than cutoff 5 mm. But unfortunately, lower the cutoff means more women will be pushed to screening, and more women, there will be more false positive, more fear of cancer. So how to decide? Adopting a more than one cutoff value may allow the interpretation of tests to be tailored according to the patient's pre-probability, that is a high-risk group. So if a patient is a low-risk group on hormone therapy, on tamoxifen therapy, then you can set a cutoff point of 5 mm. But if she's a high-risk group having all factors which you have discussed earlier, then you should put a cutoff value of 3 mm. So this is the TBS finding. Endometrial more than 5 mm, low risk, she will need office biopsy and further evaluation. If high risk, definitely you have to evaluate. But if the endometrial thickness is less than 5 mm, then you can follow. But if she is having symptoms, then you definitely have to evaluate her further. So these are the different cutoff endometrial thickness cutoff values for a postmenopausal woman with such conditions. You see tamoxifen, the cutoff value is 8 mm. So if the 4 mm or 5 mm thickness is there, you don't have to worry, because now the new is, it is 8 mm. Mostly the women with this condition, the cutoff value lies between 4 to 5 mm. Now again, this slide I have put not for to etiology of postmenopausal bleeding. I just want to say, any women coming with postmenopausal bleeding, don't stamp it as cancer, don't get fearful, and don't make the patient fearful. The rate of cancer is only 10%. There are many other benign conditions which can be treated by gynecologists, which can be identified, and no need to refer to us. Most of the patients which are coming with postmenopausal, many of time we find that they are polyps, and very common in our country is they take blood thinners, and because of blood thinners they are having endometritis, and they come with endometrial carcinoma and postmenopausal bleeding, and they have fear, and they'll end up doing hysterectomies. So these are the reasons we have to have all the thing, and endometrial cancer should be one of the last diagnoses. So this is endometrial hyperplasia. You can see well-defined echo around the endometrium, and there's a well line of demarcation. This is not my subject, but my friend is a very good sonologist, and with her I have learned many things. And this is endometrial carcinoma. There's a loss of the interface. There's a polyp you can see in the sonography finding. And this is the same time you can see there are the thick endometrium. Good sonologist definitely can identify malignancy. This is a malignancy. You can see there is endometrial malignancy and a collection. In such type of patients, if you take an endometrial aspirate, and if there is a chronic infection, and if you say there was nothing and I did a hysterectomy, is not justified. If your findings are not correlation, you have to correlate your sonography finding with a histopath. If they are not correlating, if you see a lesion, better go for a second type of investigation, or DNC or hysteroscopy. Never try to miss. It's better to have two investigation rather to miss a patient and treat incompletely. Saline infusion sonography. The introduction of intrauterine fluid during the transvaginal ultrasound is one of the most significant advances in the ultrasound in the past decade. Uterine fibroid adenoma generally are apparent on ultrasound because they are intracavity, they are merged with the sonography, and they appear as endometrial hyperplasia or thick endometrium. Uterine polyp may appear as a thickened endometrial strip, but this and submucous myopathy can be clearly identified as a feeling defect when seen on saline sonography. Endometrial thickness, it becomes non-specific, but if you add saline sonography, you can see this was a thick endometrium, but you can now define the polyps. So these are the different methods. It is very much useful in Western world where women are not very eager to go for invasive procedures. Now you can see there is a thick endometrium, but when your saline sonography was there, you can see the polyps. So these are the different methods. Very popular in countries where screening is routinely done for CA body uterus. A transvaginal sonography, when the endometrium cannot be accurately measured, or when there is a non-specific thickened central endometrial complex, sonohysteroscopy can provide additional information. And to direct a patient to visually guided hysteroscopic procedure, or unnecessary do a blind procedure and have a wrong report. So these are the thick endometrium. You can see there is a leiomyoma. So this can also help you to guide whether you want to go for hysteroscopic resection, you want to go for diagnosis. So this is a very good modality. Same way you can see the thickened endometrium and the saline infusion. How to count the endometrial thickness in this? You have to cut the saline infusion area and you get the endometrial thickness. Endometrial carcinoma, as I said, this when a saline is infused, you can see a collection, a huge necrotic mass. You cannot justify who took a small biopsy because sometimes in the periphery, the mass is necrotic, infected, blood. So when you take a simple biopsy, you will land up only in having necrotic tissue and a negative. So such type of case, and it is always better to a DNC. Even I don't advise hysteroscopic guided DNC because these uterus are very soft. If you do a hysteroscopy, there's a likelihood of perforation. Now, coming to the diagnosis biopsy procedure, we have a gold standard technique, that is DNC. People think that it is now outdated. It is not outdated. It is very much in need of each and every procedure has its basic value. You should know where to apply what. Outpatient endometrial aspirate biopsies are available like PPLE, probate, office hysteroscope, and hysteroscopic guided biopsy. Now, these are the instruments. This is a small thin PPLE and a piston. These are various type of instruments available. This is a syringe and this is a cannula which can be inserted and you can take the biopsy. This is the procedure. Now, this seems to be very easy, but when you come in the clinical practice, when a woman is very obese, it's very difficult to assess. So it's very difficult. 90% time it is easy to do this procedure, but in menopause, 70-year female, os is tight, close, not accessible, then it is very difficult. So things are easy, but still your experience counts in such patients, and you have to go for alternative method for diagnosis. Drawbacks of this procedure is one of the difficulty with using endometrial strip as a criteria for further diagnostic test is that the several conditions may be present that gives a false reading on the endometrial strip. This is particularly true if the patient is having polyp or on tamoxifen therapy. Tamoxifen causes subepithelial edema, and that may present as endometrial hyperplasia, thickened endometrium. Office hysteroscope, 16% false negative rate when the lesion is very small or a polyp, or when the cancer is very small, not covering the endometrium, there are many chances of false negative rate. Hysteroscopic guided biopsy is one of the best method. Immediate office evaluation, visualization of endometrium and endocervix, ability to detect the minute endometrial pathology, to perform directed biopsies, also allows visualization of the cavity, assessment of structural abnormalities, directed biopsy of specific lesion. It is a one-stop gynec treatment policy, but the thing is, it is a cost-effective and it is a technology. You have to learn the procedure. And the hysteroscopy routine which is done, the sensitivity is very good and specificity is very good, but I will not recommend in a stamped case of endometrial cancer. Hysteroscopy is very good for a young patient, endometrial cancer, undergoing fertility preservation and having hormone therapy, and you have to evaluate every 3 monthly. So that it is a very good modality. Or any woman of 40 years, you're going for IVF, you want to see endometrium, you want to see an annulation woman or a PCOD woman. So then hysteroscopy is better, but in a stamp case of malignancy, I will not recommend. It is better to go for a DNC. So these are the different hysteroscopic pictures. You can see a polyp. This is the normal endometrium. These are the different pictures you see when you stamp them as endometrial hyperplasia. These are different type of hyperplasia you see. Dilatation curettage is a gold standard, especially in periphery where you don't have any other method. DNC is the best method, and the accuracy is 90% at the time of hysterectomy. And hysteroscopy guided DNC, it is 98% accuracy. Management of PMB. All women with postmenopausal bleeding should be investigated. TVS is an investigation of choice. You should look into endometrial thickness, structural abnormalities, polyp, fibroid, and exclude extra ovarian malignancy. Measurement of endometrial thickness aim to identify the underlying cancer. If the 4 mm cutoff value is taken, then chance of cancer is less than 0.8%. Based on ET, how do you proceed? 4 mm, no treatment required, observation. More than 4 mm, biopsy is recommended. If you find out polyp and fibroid by TVS, then it's better to go for hysteroscopy and biopsy. Hematometer, pyometer, never do a hysteroscopy. It's better to do a DNC. Thick endometrium, malignancy, better to do a DNC. And any woman more than 55 years of age, irrespective of endometrial lining, if she's having bleeding, kindly do a biopsy is a must. 2 mm, I don't want to do, you just observe, no. And the reason behind is endometrial cancer based on the hormonal status and epidemiologic background. There are 2 types. One is hyperestrogenic, that is a fat lady, obese lady, hypertensive, between age to 60 years, and easily diagnosed. When they come into your OPD, you know this is endometrial cancer. They have hyperplasia and sonography. They're good prognostic tumor. But the other variety is very challenging. These are hypoestrogenic. They are thin and lean patients. They are women more elderly, 60 around 70. They have atrophic endometrium. Sometimes it's not even difficult to identify the cervix. So these are the category you should not miss. And these women, they come with advanced cancer because late diagnosed. So clinical practice, more than 4 mm of endometrial thickness should be evaluated. Abnormal vaginal bleeding after menopause should be evaluated. Now, this is the new classification of endometrial hyperplasia. Just to give a word about it, first we knew that endometrial hyperplasia is 2 types, that is simple, complex, atypia, without atypia. Now it is divided into 2 categories: benign hyperplasia, atypical endometrial hyperplasia, or endometrial intraepithelial neoplasia, or well-differentiated carcinoma. The second category is now put up as a pre-cancer condition. So you have to treat this patient. Atypical complex benign hyperplasia now is shifted to benign hyperplasia, which doesn't require further treatment, but atypical endometrial hyperplasia you have to treat. Now, risk of endometrial screening, as we know, it doesn't have any benefit. Moreover, what it does is endometrial screening in general population will not improve the health of woman, will have more false tests, more false positive results, and side effect, because we know hysteroscopy does have its own complication. Even DNC, we have seen perforations. So any diagnostic invasive procedure has its own limitations. Now, the British Gynec Cancer, now coming to recommendations of screening for uterine cancer, the British Gynecological Cancer Society, evidence does not suggest that screening asymptomatic women in general population with ultrasound or endometrial sampling improves any outcome of endometrial cancer. But a woman with Lynch syndrome should be offered annual screening with ultrasound, sonography, hysteroscopy, and endometrial sampling from the age of 35. After counseling the risk and benefit, and if she is having vaginal bleeding abnormal, then definitely you have to suspect endometrial cancer. Woman on tamoxifen, if she is asymptomatic, she has to only have a routine sonography every yearly. But abnormal vaginal bleeding is there, then you have to go for sampling and biopsy. These are the National Cancer Institute of US, where they have recommended that ultravaginal sonography it should be used or commonly used to examine women who have abnormal vaginal bleeding regardless of age. Women with Lynch syndrome, transvaginal sonography should begin as early as age of 40-25. Tamoxifen women should be screened with sonography, and if they have abnormal uterine bleeding, then you have to evaluate further. These are the American family physician recommendation. They are mostly the same after the 65. If a woman is symptomatic, you have to do a screening method. Woman with abnormal bleeding should be evaluated for endometrial cancer if she's 45 or old. In any postmenopausal bleeding, more than 5 mm of endometrial thickness has to be evaluated. These are the newer things which are coming in the endometrial detection, cancer detection. We have now a Tao brush, which is used mostly in the Western countries, mostly on the Eastern countries like Japan, where they take a brush from the endometrial cancer. It is like a pap smear screening. It is a cytological screening. Second thing is a microcolpohysteroscopy, which is a new development. It offers distant panoramic vision, very close to the contact, and has a very high magnification, and it sees the cells in process. So this is a very high type of magnification is seen in the endometrium. This technique still is not available in India. These are the new aspect of screening. They don't only screen for hyperplasia and TVS, they also screen AH, that is atypical hyperplasia, intraepithelial neoplasia, now considered precursor lesion, and main target is to identify this precursor lesion. Then you make a great difference in the screening of this targeted population, and you can see you not only treat these women, but you can increase their lifespan. Similarly, women with abnormal bleeding, if you identify these precursor lesions, then you make a huge difference in their lifespan. Now, endometrial cancers diagnosis, in summary, screening is justified only in high-risk group. 4 mm should be a cutoff point in sonography. Office hysteroscopy is preferred method for diagnosis. Symptomatic woman, if you feel it's a malignancy, then DNC is preferred. All the method you have to judge by your patient and your skill and your knowledge. My take-home message is routine screening for endometrial cancer is currently not justified. It is only done in a woman who has postmenopausal bleeding, who is a high risk, risk, patient who has Lynch syndrome, and patients who are tamoxifen. Only 3 category women should undergo endometrial screening. Postmenopausal women need to be educated about the importance of seeking attention if any vaginal bleeding occurs. Pap smear is not a screening method, but if you see abnormal cells in the pap smear, then it should be investigated. Evaluation is must in all postmenopausal bleeding. TVS and biopsy remains the gold standard. Endometrial cancer is seen in all age groups. So you have to keep your eyes open, not only in menopause, but in all age groups. And it is a good prognostic tumor if it is diagnosed early and properly treated. Thank you very much.
Can I speak now? Can I speak now? Okay, good evening, everybody. I am Professor Bharti Mishra from Odisha. My regards to Kamal Bakshi madam and my regards to Sadhana madam and all the dignitaries and all the speakers. Thanks to Sadhana Gupta for doing such a nice thing even after 6 days of the cancer screening program. What lines she has told that all gynecologists are preventive oncologists, very, very nice word. And being in the tertiary hospital myself, we do a lot of screening. Recently, we have done a pap smear room itself. Pap smear, HPV, if possible, we're doing. And also downstaging of cancer service. I do myself with all my sisters and all my staff nurses. And because of the COVID, we are not back. I have sent message to Mohila Samiti, Vaisya Samiti, Marwadi Samiti, all my friends, all elite group, non-elite group, to have a pap smear, at least 10 from their friend and colleague, and send me the report so that I can see by pap smear and comment them. So that is the way you can propagate and you can screen to decrease mortality due to cancer cervix. Because as we have discussed already, cancer cervix mortality 1 in 8 minutes, more than maternal mortality or mortality due to abortion and septic abortion. So why not that? Cancer, you are doing so much prevention, Madam Sadhana Madam, the future president. You have to look to that. Government has to make it free, HPV vaccine. When the COVID they are making free of cost, and why not HPV they have done in schoolgirls? At least in schoolgirls they should have given. And we have to fight for that. So this is one part. So we have to do our screening program at our level without seeing that COVID is there or is not medical college, not like that. All my students and staff nurses and pharmacists, whoever in OPD, they have to put a speculum and see that one in busy OPD also. And we have done a screening also by DNC and other things in my OPD. But Anjana, very nice talk, very nice talk. And the endometrial carcinoma is very close to my heart. Why, you know? I have done a thesis, 1985. I have completed my thesis in aspiration cytology as a screening for postmenopausal, perimenopausal women for endometrial carcinoma. That time I have done. And that I presented to my youngster to do that one. So the screening program, you told that you will not do for all patients. We can do. And the corpus cancer program and their outlook for Western countries is same, not like India. We are different. Our constitution is different because we have seen, as you have told, even without corpus cancer, thyroid, obesity, etc., thin build, poor lady, multiparity with endometrial carcinoma. Recently, just 15 days back, I did a endometrial carcinoma and I kept as a specimen for my students. It was a 16-week size, thin lady, no symptom, only white discharge. But such a growth, and I have done a fusion section. I have requested them, don't destroy the specimen, keep it for studies. So things are changing, not that protocol of the cancer, Lynch syndrome. How many of you have seen? Lynch syndrome history anybody is taking? So Lynch syndrome, everything is possible in Western countries. They are doing a lot of screening from history, protocol, and documentation. In big institutions, it is possible. But in our institution, we are taking the family history, etc. But that is not that possible to detect Lynch 1 or Lynch 2 or HSPC, etc. So we have to screen all postmenopausal lady, whatever Anjana madam has told like that. And I do. In a OPD, I do only DNC for other things because there's no bed. But for postmenopausal, perimenopausal lady, I tell that you will have to admit. We give a misoprostol tablet and we do a fractional curettage, preferably under anesthesia. Nothing can beat us than fractional curettage. Plenty, profuse like gritty coconut, and the endometrial cavity sensation will not be known. That is the hallmark. You will see plenty. And in doubtful cases, I have fought to government for 10 years to give us an office cystoscope. They are not giving. That's the one-stop treatment. But if still not available, we will not screen. We'll screen with our modality. Pap smear is one type of screening. Babra aspirator, we aspirate. And even Karman's cannula, small one, with a misopostal, you can do it, curettage and take it. Even pap smear, sometimes we can detect an abnormal smear if the cervix is healthy. Think of endometrial carcinoma. So fractional curettage, histoscopy if it is there, and Babra aspirator, people, everything is theoretical. That can be there in good all high-tech institution. It is there also, and this is nothing great. When we are purchasing in a government, we are purchasing robotic 20 crores rupees. Can you not provide all these things? They don't look, but we are not defeated. Our society with Dr. Indra Palo and Secretary and our President Sanghamitra, we have done campaign and we have done screening for all doctors for cancer cervix and HPV. And we have sent all these things and we have done pap smear and different society. I told all the society, I am intimately related for health education. So I brought them and did a pap smear, 100. Like that we do in army cantonment also. We have gone with a group. So what I mean is that, as Sadhana Madam is told, every gynecologist should be a preventive oncologist. Very good things he has provided. We have to decrease that. It's a preventable. And primary prevention, HPV vaccine, I give in my clinic. I send to them to SPM department and other fellows who are giving. We have started. So we are telling 10 parents, one is obliging. So let it be. So 1% will be cured. So that is the thing. So thank you very much for making me part of Gorakhpur society. And I wish all those who have stand should send me. And one point I'll tell, and Sadhana will not believe, before presidency, everybody used to visit our society, maybe for academic. And those who have come, they have visited my residence also. And they like my residence because I have done little bit ornamental things. Leave it. So those who have come, they have also won. But don't worry, without coming also, so academic you are and enthusiastic. I have seen you working day and night in all the conferences. We wish you all the best and all my participants. God bless you all. And I am quite senior. I am the next to Kamal Bakshi Madam. Probably I am the senior most. I have rejoined after HOD retirement in MKCG. I have again rejoined on request of government for 2 years. I am very much happy because academically involved. Today also, fortunately, our seminar was preponed to 12 minutes so that I can attend at 5 o'clock. From 5 o'clock, I am here, though I am blocking. So thank you very much. Good evening, everybody. And wish all Sadhana Madam should come up, and also all the participants, please send your biodata and everything to me. I'll circulate. Thank you all.
Thank you, ma'am, for your brilliant analysis. And now I request Dr. Bharti Rajshekhar ma'am to give her valuable remarks. Dr. Bharti ma'am.
She's muted. She's muted.
Yeah, she's muted.
Yeah. Aruna, you may request again.
Dr. Bharti ma'am, your
yes,
valuable
I'm here.
remarks.
I'm sorry.
Yeah, valuable remarks.
Yes, Dr. Anjana, your talk was so crisp and explicit. And as you said, the point to be noted is, one is a clinical examination and suspicion is of utmost importance. And the second point, which I really liked, was not all postmenopausal bleeding is endometrial cancer. Please think of the more common causes like atrophic vaginitis, which is a very, very common issue in postmenopausal bleeding. And of course, as you said, towards the preventive aspect of endometrial cancer, I think the PCOS population has to be counseled and has to be tackled in their younger age. Otherwise, we are going to see a huge splurge in the incidence of endometrial cancer in the coming years. One is due to PCOS and the other one is due to the indiscriminate artificial reproductive techniques which are being used, not following the guidelines. So I think you have covered everything excellently, and I have put a request to, if you could share your PPT, because I am talking to the postgraduates next week in Karnataka on prevention of gynec cancers. And then without wasting much time, I think we should go to introduce the next speaker, Dr. Kanchan Sharma. And she will be speaking on breast cancers. And here I have a tip that each one of us need to put, and even we have to train our staff, that each woman who walks into our outpatient, our hands need to go to her breast. Breast is not the domain of the general surgeon, but the breast is the domain of the reproductive physicians, I feel, and we are there. We need to put our hands on each and every breast that comes into our outpatient, and we need to train our paramedics that when they do the initial assessment of the blood pressure or weight, let them examine the breast and teach them self-breast examination, which definitely goes a long way in preventing breast cancers. So I request the CV of Dr. Kanchan Sharma so that we could go ahead with the introduction.
Disturbance is going on. Please mute others. Vashisht, please mute others. Some TV is going on in somebody's house. Okay, Dr. Bharti, are you going to continue? Hello?
Yeah. Thank you. And now I have the privilege once again to introduce a very eminent reproductive surgeon, Dr. Kanchan Sharma. She is the Director and Chief Consultant of Akash IVF Center at Kanpur. And at the present, she is the Secretary of the Kanpur of OB-GYN Society for 21-23. And she's also the President of IHRF in Kanpur. Her resume runs into pages, as you all see here. She has served as the Vice President of the Indian Medical Association, served as the Honorary Joint Secretary of IMA, Library Secretary of IMA, and she has been in the Joint Cultural Secretary, and she's been a very active member of the Indian Medical Association, and I think that goes a long way in preventing cancers, to promote prevention of cancers. And also she has been serving as Honorary Secretary of FOXI in Kanpur. She's the President of Infertility and High Risk Committee of Kanpur. She's been trained in ultrasound and ART and operative laparoscopy. She's been an organizer of various national and international conferences, and she has also received various awards. She's won the Best Paper Award and Best Speaker in many conferences. She's a recipient of the Pratikya Social Impact Award from New Delhi, and Association, the Nari Ratan Saman and Corona Warrior Award by the Arya Samaj, and she's been part of the Mission Shakti, Nari Suraksha and Nari Saman from the Police Commissioner of Kanpur, and she works in public awareness, adolescent and study of the female breast, which is also few of the topics which are very close to my heart too. So I think we are both on the same page, and I now request Dr. Kanchan Sharma to take over the platform.
Thank you very much, Dr. Bharti, for your nice words. May I share the screen? My screen is visible.
Yes, it is visible.
You have to go to slideshow. Yeah, that's it.
Yeah. So at the outset, I, Dr. Kanchan Sharma, Secretary of Kanpur Obstetrics and Gynae Branch, pay my greetings and regards to Dr. Sadhana Gupta ma'am and Gorakhpur Society to make me a part of this webinar series. I pay my regards to President ISOPARB, Dr. Usha Sharma, and very humble Secretary, Dr. Meena Samant. The relation with the Gorakhpur is way back. I have a long relationship with the Gorakhpur. I remember that first of all in 1989 when I came to present a paper on premature uterine contraction and got the won the best paper award at that time with Dr. V.K. Singh. After that, many times physically I was there to deliver some lecture to Gorakhpur, and all the society, all the members of the societies are near my heart, and thanks a lot. Pay my regards to all of you. Dr. Reena Srivastav is here. Dr. Sadhna ma'am is here. And my topic, because I am a last speaker, but my topic is very important as we all were discussing since long. The breast cancer is one of the most prevalent cancer. If we come to breast cancer in India, the breast cancer is the most common cancer among the women in India and accounts for 27% of all the cancers in the women. If we see that overall, 1 in 28 women are likely to develop breast cancer during their lifetime. This is very important data that breast cancer in India, 2,000 new women are diagnosed with cancer every day and 1,200 are detected at the later stages. If you see the breast cancer mortality rate in India are even 1.6 to 1.7 times higher than the maternal mortality rate. They go more. With the pink, I have depicted the breast cancer mortality rate, and with the yellow, the maternal mortality rate. You see, this is more. Breast is a reproductive organ. It's an integral part of the gynecological examination and is the examination of the breast. Very important. We gynecologists are preventive oncologists. Very right theme has been given by Dr. Sadhna Gupta ma'am. It is an important sex organ. Breasts are made up of hormones, responsive tissue which develop at the time of puberty. It is an important reproductive organ that undergoes changes during pregnancy, during lactation, and the late reproductive years. It is an important sex organ that influences body image and the sexual function. The gynecologist may be the primary physician, sometimes the only physician seen on a regular basis by the women of the childbearing age. Such periodical examination should continue even after menopause. So cancer of the breast is recognized more often by the gynecologist than by any other physician. We all agree with it. Gynecologists must be trained in those diagnostic procedures that are important in revealing the nature of the breast nodules. The obstetrician and the gynecologist, for them, the breast is an organ of reproduction, and complete breast examination is a part of obstetrics and gynecological examination. So in addition to history and the physical examination, the obstetrician or gynecologist should be prepared to undertake simple diagnostic studies. Cancer, on the other hand, presents a number of challenges. The appropriate role of the obstetrician or gynecologist is one of the surveillance and as a resource for the patients, including the discussion of the risk factors and the treatment alternatives. This is very important line, that as a resource of patient, including the discussions of the risk factor and the treatment alternatives. All the gynecologists should examine patients' reproductive organs as well as breast, and also teach their patients how to examine breast herself regularly. How to examine breast herself regularly, very important. These help to test for breast cancer and the cervical cancer. The American Board of Obstetrics and Gynecology has recognized the special role of the obstetrician and gynecologist in the diagnosis and the treatment of breast disease, and they have acknowledged that it should require a knowledge of breast disease and in its certification process. All obstetrician and gynecologists should participate in the breast cancer screening and help detect this malignancy in its early stage. During patient's visit, gynecologist can perform a breast examination and pap smear. All of us should do, as Dr. Kamal Bakshi ma'am has also mentioned, that as a patient walk in your OPD, you start examination from the breast, then all the other organs. During a breast examination, a gynecologist will feel for lump or enlarged lymph nodes and check for skin changes that can indicate the breast cancer. They should have these type of charts in their OPDs, and during advice post-delivery while breastfeeding, you can sensitize them about if you see any discharge from the nipple like this, if you see any differences in nipple, you may see damaged nipple, rusty pipe syndrome, benign intraductal papilloma or mastitis, or if you see any lumps, it is hard to touch or a pebbly surface or commonly located in upper outer quadrant of the breast or does not move during the breast self-examination, you should report to me, to your gynecologist. During feeding, you should advise them that you should check your breast for all of these things. During these camps, you can just familiarize them with the normal breast anatomy so that they should be more familiar with it and free from any hesitation to come out about their problems. They should understand by the diagram what are the benign conditions and what are the malignant conditions that may be there. You should have these type of diagrams in your OPDs, and you should make them understand that there are different conditions which can cause breast cancer. These may be conditions which are modifiable and the conditions which are non-modifiable. Modifiable conditions you can control by yourself. If we talk of obesity, one can control by the exercise, by the diet pattern. Hormone replacement therapy increases the chances of breast cancer. Alcohol, smoking, tobacco.
So near and dear to me that I thought that I should be not be taking this opportunity.
Sorry.
Because this is something which I take pride on.
A mother seminar is going on, it seems to be so.
If the patient is not breastfeeding, then there are more chances the patient who is not having any children, usually because nowadays they are planning late. They are studying and going in some work and they are planning late. There are more chances of breast cancer. So what are the risks for breast cancer that should be enumerated to them? Gender, it is that more common in the female, and if we talk of the race, more common in the whites, and ages, it increases as women get older. And if there are more chances if first line relative like mother or sister is suffering from the breast cancer. Menstrual history, if we talk, if there is early onset or of the menarche and late menopause, there are more chances. And first child after the age of 30 or having no children at all, there are more chances of the breast cancer. So the risk factors for the breast cancer, as we have discussed, obesity, diet, lack of physical activity, radiation exposure, history of the cancer in the family, and hormones, and genetics is a non-modifiable factor. Genetic, like they are more prone in certain families having certain genes, BRCA1 and BRCA2, that we will discuss later on. This is very important point, an important slide which I am going to discuss, that we all over India are 35,000 gynecologists almost, as we see. Screen 5 women every day. If each gynecologist will screen 5 women every day, 35,000 into 5, that becomes 1,75,000 women screened daily, very important. And throughout the year, 5 crore 25 lakhs women were screened every year. So, yes, we can do together, should join the hand for screening. This is very important message. Let us begin by screening, and because we have to make it understand that our patient should know it. What are the components of the breast screening? The components of the breast screening are self-breast examination, clinical breast examination, mammography, digital versus screen film mammography, MRI screening, ultrasound screening, and newer modalities. So, but we have to teach to our patient that self-breast examination is very important. What is this? And what is the clinical breast examination? A self-breast examination is a clinical breast examination performed by healthcare professional. That is a clinical breast examination. Is performed by healthcare professional to detect any abnormalities and the warning sign. While self-breast examination is done by the woman by herself. Self-breast examination, there are few steps. I'll go hurriedly because you have to make them, gynecologists should know it, because they have to explain to their patient. First, stand before a mirror and look at both the breasts. Check your any unusual things such as nipple retraction, redness, puckering, dimpling, or scaling of the skin, and look for the nipple discharge. Next, she has to press hand firmly on hips and lean slightly towards the mirror as you pull your shoulders and elbow forward with a squeezing or hugging motion as I have shown in the diagram. Look for any change in the normal shape of your breast. So looking in the mirror, second, you can raise the arm and rest hand behind the head. This allows to see the underside of the breast. If there is any lump, any malignancy, you can see in this posture. Now, as shown in this diagram, place the left hand on your breast and reach into underarm area and check for enlarged lymph nodes. Also check the area above and below clavicle to be done on the both sides, as shown in the diagram. Now, the patient will raise the left arm and use the pad of 3 or 4 fingers of the right hand to examine the left breast. Use 3 levels of the pressure. This is very important. You suggest her see by light, medium, and the firm pressure while moving in a circular motion. Beginning at the outer edge of the breast, use flat part of the finger, moving in circle slowly around the breast. Gradually, make smaller and smaller circle towards the nipple and check behind the nipple as well. Lie flat on the back with left arm overhead as shown in this diagram and a pillow or folded towel under the left shoulder. This is a diagram showing applying different level of the pressure and see for any lump. In short, I have shown all this in a diagrammatic fashion. These pictures you should have in your OPD just to make understand to your female patients. Now coming on the clinical breast examination, that is to be done by doctor or your clinical attendant. The patient should undress to the waist, seated with arm by the side. See the size, symmetry, shape of the breast, skin color, lump, skin tethering, prominent veins or edema of the skin. See for the nipple, whether this is everted, flat or inverted. Cracking or eczema, gross deviation of the nipple, bleeding or discharge, areola, observe for abnormal reddening or thickening of the areola. So, the sensitivity of the clinical breast examination, National Breast and Cervical Cancer Early Detection Program says is 58.8%, while its specificity is 93.4%. So this is very important examination which should be done and very easy, non-invasive, can be done in OPDs by us, and to be advised to the patient to be done at their own home. This again, the diagram shows that you see the position, size, shape, and puckering or dimpling, swelling or ulcer, size, shape, and surface. Skin over the breast is very important. Color and texture, engorged vein should be seen, dimple retraction or puckering, orange, nodule, ulceration, all the presence, position, number, size of shape and surface, and the discharge and inversion, color of the areola, size, surface, and texture. These all points should be remembered very well. When you examine, you should examine arm and thorax of the patient, axilla and supraclavicular fossa on raising arm above the head. This examination, this point is very important to see the lymph node also. Do the palpation also in sitting posture, in semi-recumbent and recumbent position. Palpate normal breast first. This is very important point. Palpate normal breast first and palpate with the palmar surface of the finger, with the hand flat. Normal breast is firm lobulated impression. 4 quadrants to be palpated systemically. Axillary tail should be seen and nipple should be examined. If you detect any lump, see its local temperature, tenderness, situation, number, size and shape, and surface and margin. Of course, consistency, fluctuation, trans-illumination by a torch, fixity, skin, breast tissue, fixity of the skin to breast tissue or underlying fascia and the muscle, and the chest wall and palpation of the nipple is most important. This is examination for the lymph nodes. There are different groups of the lymph nodes: pectoral axillary lymph node, subscapular axillary lymph node, anterior posterior humeral axillary lymph node, lateral central axillary lymph node, some apical axillary lymph node, and interpectoral lymph node and apical axillary lymph nodes. These are the way of examination of all these lymph nodes. So what are the guidelines for the clinical breast examination? ACS says that every 3 years from ages 20 to 39 and then annually, while ACOG and NCCN recommends every 1 to 3 years from ages 30 to 39 years and then annually, while Canadian Task Force says that every 1 to 2 years starting at the age 40 years. Although the guidelines, they vary for the low risk, average risk, and the high risk patients. For the average risk patient, women between 25 and under 40 years, the NCCN panel recommends CBE, that is clinical breast examination, every 1 to 3 years, and the breast awareness is encouraged. For the women aged 40 years and the older, annual clinical breast examination and the screening should be done, mammography, and encourage breast awareness. That is very important. For high risk persons, where there is a prior history of the breast cancer, history and the physical examination 1 to 4 times per year as clinically appropriate for 5 years and then annually should be done. Mammography is recommended every 12 months for these patients. Women on tamoxifen, we should do the annual gynecological assessments every 12 months if the uterus is present. And if no clinical symptoms or the sign of recurrent disease, no need of metastasis, screening is there. Women on aromatase inhibitors should do bone health checkup and monitoring. So, women suggestive of or with a known genetic predisposition. In these cases, we encourage breast awareness and clinical breast examination every 6 to 12 months, starting at the age of 25 years. Annual mammogram and the breast MRI as an adjunct to mammogram starting at the age of 25 years or on an individualized timetable based on the earliest age of cancer onset in the family members. Offer risk reduction counseling and strategies in these patients. So coming hurriedly on the different methods, that is screening mammography. This is very important procedures in the high risk patient. Its goal is early detection of the breast cancer. This is the only screening modality to have shown decrease in mortality. This is advantageous because it has a low cost and low radiation dose and have a high sensitivity. Interpretation as shown in the figure, we are doing like this. It shows the fatty tissue. It shows the glandular tissues as I have seen in the diagram. This is a fatty tissue, glandular tissues. They are seen different pectoral muscles and axillary lymph node calcification, calcium deposit are visible in this. Fluid filled cyst tumor dense, they appear dense or sometimes appear bright on images. We have a two type oblique view and craniocordial views in this. Now coming on the tomosynthesis. What is tomosynthesis? It is a digital tomosynthesis created three-dimensional picture of the breast using X-rays. The X-ray tube in this moves in an arc around the breast while 11 images are taken during a 7-second examination. But it does not replace mammography. It is an adjunct to mammography. Guidelines: the screening mammography, ACOH, ACOG, ACS, NCCN and ACR, they say that they should be done annually beginning at the age of 40 while the Canadian Task Force says annually for women ages 50 to 74, while others say that every 2 years for women ages from 50 to 74 years. The screening MRI, the sensitivity of MRI of the breast cancer detection is estimated at 71% to 100%. If we talk breast MRI versus mammography, sensitivity of the breast MRI is more, while specificity is less, resulting in higher rate of false positive findings. Breast MRI has never been directly compared with the mammography in general population. It's an adjunct to mammography, is not the replacement, and is done in high-risk patients. Because this is not cost effective. So its indication is annual MRI is an adjunct to mammography starting at the age 30 is recommended for the women with a known BRCA mutation who are untested but have a first degree relative with the BRCA mutation, who had been treated with radiation to the chest for Hodgkin's disease, who have an approximately 20% to 25% or the greater lifetime risk for the breast cancer based on specialized breast cancer risk estimation models. So screening sonography coming on, this is a because ultrasound machine we have nowadays near our OPDs. So this is a easygoing procedure for all of us. The American College of Radiology and Society of Breast Imaging recommends screening sonography as an adjunct to mammography in high-risk women who cannot have an MRI.
Sorry to interrupt, Kanchan ma'am. Only 2 minutes left. Sorry to interrupt you.
Okay, so hurriedly going on the different methods, elastography is a very important method nowadays, and the newer modalities are molecular imaging, And what are the problems of screening? There are pain and discomfort, and sometimes they are overdiagnosed. These are some problems. So conclusion, mammography is the only screening modality proven to have decreased mortalities. Clinical breast examination is one of the most important methods for the breast cancer detection, especially in countries that lack screening mammography. MRI and USG are used only as an adjunct to screening mammography in high-risk population. ACC to NRHM and the Health for All breast self-examination and the breast awareness are the first step towards creating nationwide screening program. So we should understand our patients these 5 steps. The October is the nationwide awareness month. So NWPC, now the 4th Feb was cancer awareness. We all have celebrated. NWPC is doing our part to educate our community by covering the best practices around early detection and information, and when to visit your doctor, because this disease is the second leading cause of the death among the women. Early discovery essential for saving the lives and can increase your 5-year survival rate by 99%. So people should know that what can they do to protect them against breast cancer. This is very important. So FOXI and ICOG recommendation for all the obstetrician gynecologists, they should understand breast cancer, basic step required for diagnosis and treatment. Breast cancer more individualized depending extent of the disease and individualized tumor features. Mucin 1 vaccine already being told by Dr. Sadhna ma'am. So breast disease is an important as any other woman's health issue. The identification of occult breast disease could be the most important contribution by the gynecologist making during the routine examination of the woman. Breast disease should be included in the teaching program for the gynecologist, should be covered thoroughly enough to enable the gynecologist to confidently make a diagnosis of both benign and the malignant disease. Given the incidence and mortality rate of breast cancer, breast screening must be a part of primary care of all the women. Thank you very much. Together, yes, we can do, we can give our lot much of contribution in preventing the breast cancer at all. And again, because I'm contesting for the chairperson of study of female breast committee with the folded hand, I beg your say for your blessings and vote and support and all. To all my seniors, regards.
Thank you, Dr. Kanchan ma'am, for enlightening us. Everything was very well depicted in the charts form. Now I request Dr. Reena ma'am for her valuable inputs.
Thank you, Aruna. Since
Kanchan,
today
you
evening,
stop share, please, so that Dr. Reena ji can give. Yes.
Since today evening, we have been talking of prevention of the major cancers in a female, and screening. What do we mean by screening? Screening means it should be a test which can be applied to all, which is cost effective and which gives a highly sensitive result. It is not that each and every test can be applied for screening. Screening means it is not an opportunistic screening. We should go for the whole masses, and then all the tests we are knowing, and as an adjunct, what we have talked about, it cannot be applied to all. So we should start from the small things which have been in our curriculum since ages, like, so out of all the 4 cancers, cervix is accessible, breast is there to examine, and that can be very well done in your clinics. And for the masses to come for screening, they should be aware of it. Most of the people, they are not aware, and the awareness programs are being done in kits and bits by us, by the government, by so many social workers, but still the awareness needs to be to have a good concern about it, so that the patients can be examined, and we should have a structured program for it. Still, it is not there even for cancer cervix, although WHO is showing a great concern to it, and there are nodal officers also state-wise to look after cancer cervix in our UP also. I think Dr. Uma Singh is taking care of it. But screening for cervix is easy because you can do a speculoscopy, you can you can do Willy, you can do VIA, you can take a pap smear, you can do HPV, everything is on the cervix and you can go for it. For breast, it is so easy that a self-examination to be done every month and a clinical examination every year. And according to the various bodies, go for mammography after 40 years every year or 2 years, or after 25 years in high-risk cases. Ovary, endometrium is inside the womb, we cannot see it. We have to because we cannot subject every woman for screening of endometrial cancer. It is always symptomatic women and high risk cases. Then ovary is somewhere behind or below the uterus and hiding itself, and it is the most notorious one. And still no program of universal screening is there for it. But what I have to say that yes, history is very, very important regarding a cancer in the family. Any kids and kins in the family is having a cancer of breast or uterus or ovary or endometrium, whatever, or colon, even in the male subjects in the family. Those patients are high risk, and then they can be subjected to genetic sequencing, and then they can be subjected to early screening. And what we were talking of salpingectomy or salpingo-oophorectomy after completing the family. So we have got few modalities which we didn't have at all, say a decade back or 2 decades back, and more women were going for the mortality out of these cancers. But still we are in a better position. The gynecologists know so much about the prevention. Whatever we can do, we should put in our efforts. Please do a breast examination, please do a speculoscopy, please do a villi, whatever patients are coming. But Sadhana, I wish you to be the president of OBGYNs, All India OBGYN Society, and take this forward that every woman to be subjected for screening program. And my best wishes and my all wishes to all the contestants sitting over here. 5 log yahan baithe hain. And my hearty wishes to all of you to come up and take this vision forward, because India is a very populous state, and to screen every woman is definitely a very, very difficult task. And through our bodies, so many people are doing a lot of work, but then it is not sufficient. And screening means to screen all women. It is not opportunistic screening. But opportunistic screening is also bringing down somewhat the incidence and mortality of cancer. Still 67,000 women are dying out of CS cervix, which is so preventable. So it is our task to take it forward, and we should be very clear that screening mein humko sare test nahi laga dene. We have to screen, we have to go step by step upwards, and then we have to add the adjuvant investigations. So thank you all for giving me this opportunity, and my best wishes to all the contestants.
Thank you, Reena ma'am, for your valuable inputs. Now I hand over the stage to Dr. Babita for question answer session.
Thank you, Aruna ji.
There are no audience questions,
Yes.
so Babita, you can say, I think among faculties we can little bit discussion, though we have a very, very good attendance across the globe from US and Brazil also, and around 640 in India.
Credit goes to you.
Everybody's and very good. And what Dr. Reena ji ends where we took the thread that like what is the in India and the low middle income countries, actually the tomorrow's burden is much more for the cancer in our area because of all smoking, and we have all the old thing and we have all the new things like obesity, PCOS, infertility, IVF rampant, and the old things which is the still multi-parity, sexual infection and hygiene. So rightly Reena ji says, and it should be our commitment with the future ISOPARB Foxy leadership that actually we had to be very, very loud and total advocacy for women's health, because yesterday with the Bangladesh perspective, Dr. Saiba says anything which is related to man health takes the people's priority. So it is for us that the women cancer takes the top priority, and what Dr. Bharti Mishra says, then we government can give COVID vaccination, then it can give also HPV vaccination. So right from Dr. Kamal Bakshi, Dr. De Madhu Malti, Dr. Usha Sharma, we are totally motivated and inspired with such a good attendance that everybody believes in prevention, and we all should have a very loud voice and a very good clinical mind in our practice, in our day-to-day working. This is very, very important, that we should be very, very clear that whom women needs screening, whom women are high risk, and where to do what technology. So
Dr.
thank you very much.
Dr.
Sadhana, we want you to be our voice, okay?
Thank you, thank you. So,
Now
Dr.
our voice is
Sadhana will be president. She will make HPV vaccine free of cost for all school girls. That you have to promise us. Like all leaders are promising, they are not doing, but you have to give a promise that we are going to do that. Then we are going to make you a president.
My one suggestion is, Madam.
Just I'm joking.
God willing, both things will happen, God willing.
Madam, my one suggestion is in Mediclaim, any women Mediclaim should be not passed if she doesn't have a pap smear. Any Mediclaim should not.
I think, yes.
If that thing is put to the government, the people who are claiming Mediclaim or taking all this Maha Yojana and government scheme, they should have pap smear.
We should introspect ourselves. Whether we are doing a breast screening and a pap smear for every woman, or we are doing an opportunistic screening. Introspect yourself, and that will give you the answer.
And ma'am, most important, we should get our pap smear also done. We should get our screening
for all medical doctors first. Doctors, staff, nurses, we did one, and HPV also. And as I told Sadhana, as I spoke that over telephone also you advise they'll go to nearby places, and in the COVID also they'll send the reports. So if there is SIL or CIM2 or whatever it may be, you treat them only. So they'll not go to malignancy. So that can be done. That can be done over telephone also. We can communicate our views and ideas to the mostly educated people also. They can do. Sometimes educated people also suffer. They also come in a late stage without doing any screening. Sometimes.
Educated people have their own issues actually. The ignorant are ignorant, but educated people have their own issue. Dr. Kamal Bakshi says the people don't want to
breast cancer such an important. Somebody, Madam Bakshi told no, first you change the height, weight, and get and start from breast. So one lady was coming for pregnancy. She was showing me the mother never showed, but after 3 months the mother developed breast cancer stage 4. She never told me. I have never examined the mother. So self-examination is very good. That also can be taught over by short video in the WhatsApp.
Cervix is definitely being ignored in the affluent classes because these girls are not willing to get a PS and PV done. This is very, very important. Everybody is going for they can have a TBS probe, but they'll not get a PS examination.
Right.
So that is, I don't write a prescription without examining them.
Yes.
So as a preventive, as first line preventive doctors, we are there. And they listen to a female doctor more because girls and ladies, breast cancer, breast masses, they're coming to us first. Then they're going to surgeons. If malignancy we are sending, benign we are managing.
That is
most
why
of the breast problem they are coming to us.
Yes, that is the importance of the.
That is included in our chapter. Breast cancer, where benign breast diseases is our domain. Once they are malignant, we are sending them. But we have to detect that because village people they will not show the breast to anybody. As we can see them. Even pregnancy breast we have seen. It is not high as the USA or UK, 1 in 8, 1 in 9. During my visit, I have seen whole world full of breast cancer youngsters and pregnancy.
Actually, these
but
tests are
as
very
Madam
difficult.
Sadhana has told, that we are being externalized, westernized, and they have become, so they are taking our diseases, we are taking their diseases. So that we have to be careful both ways. Like previous one and recent modification. Rightly you have told. Right? Yeah. Next.
Very
Next.
nice, very
So happy
nice
to meet
theme
you all.
chosen. Very
So
nice
very
theme chosen.
active. Yeah.
And regarding
yeah,
SWAYAM
yes, very
project,
nice.
which is
That's
coming
okay.
up, SWAYAM project,
yeah.
How effective it will be, like patients taking their own smears and that will be collected and sent?
See, if it is being done nicely and they have been taught nicely, it is going to work. But the thing is, who is going to teach them properly, and the one who is teaching is well trained or not. This responsibility goes to the TOTs.
Okay.
So if they are taking the vaginal cup for the menstruation, so that somebody has told, that's also very good, because smear, pap smear taking like that, also in a finger, also in absence of pap smear, spatula, you can also take that one, but they have to be taught that 3/4 of the slides to be covered by the smear, so that the good report will come.
The teaching has to be very, very wise and properly teaching has to be done. समझाना पड़ेगा तभी वो ले पाएंगे, नहीं तो वो बस थोड़ा सा सुपरफिशियल लगा के फॉल्स रिपोर्ट आएगा।
उसका एक बहुत बड़ा मतलब
स्मेयर ले जाएंगे।
यस, फॉल्स नेगेटिव रहा और पेशेंट इज एश्योर्ड कि मेरा पेप स्मेयर सही, मतलब इट इज व्हाट वाज नॉर्मल।
जितनी देर में उनको सिखाएंगे उतनी देर में हम निकाल लेंगे।
हम लोग बीआईए का कैंप हुआ था अभी हम लोग क्या,
एचपीडी कैन बी टेकन। अगर हम 20 लोगों को सिखा रहे हैं तो हम उनका स्मेयर निकालने में कितना टाइम लगेगा, उससे कम टाइम में हम स्मेयर निकाल देंगे।
They can do also. If they are married and they have to take their wife, that can be done also, as she has suggested.
And another thing which is very important, that always
what is that program? SWAYAM program.
A positive way. Actually, it is a positive health. क्योंकि कैंसर के नाम से लोग like ना they are जैसे they don't come out with history, so they don't come. But it is for your overall health. So this is also very important, that the positive, it should be like this should be our way actually. So Aruna, you can, I think, conclude or give vote of
Actually,
thanks.
no, the screening test cannot be made mandatory. You have seen the Western world where the vaccine was made mandatory, and you saw what sort of this thing was there with slogans and all. Why is being made mandatory? I don't want a vaccine. कितना ज़्यादा वहाँ पे शो शुरू हो गया. So that why हमने अपने village में कैंप किया था. That was pap smear and speculoscopy and VI and all. So many people came. I think Madhu was there, है ना? Madhu, you were there. And the irony is that the same village, a lady came to me in advanced stage of CSR, which she didn't come for that time. She came in advanced stage of CSR. तो ये जब आएंगे नहीं तो that is ऐसे भी percentage हमेशा रहेगा. It is not that we can cut down the
advanced stage of cancer service
unless कि सबको vaccine ना लग जाए. और vaccine
so we have to highlight that after doing a pap smear, 80 to 80% of the mortality in Western countries decreased, and 50% the mortality due to cancer service.
This will be understood by the literate class only, and the rural population will not understand. They may come, they might not come.
The NGO and other body has to be should understand this and to motivate the people at grassroots level.
So can we conclude?
And they should now be brought to the medical college or anywhere.
It's already 8:15.
Okay.
Oh yes.
So Aruna, time to give vote of thanks, Aruna.
Good evening, respected dignitaries, teachers.
Please send your flyers for those who wanted to be standing Send your flyers.
And dear audience.
Sure, madam.
Good night.
My regards to Dr. Usha Sharma, ma'am. Ma'am, your blessing is needed. I deem it a great honor to propose the vote of thanks to all in making this webinar a resounding success. First of all, I would like to propose hearty thanks to our chief guest, Professor Kamar Bakshi, for gracing the event, and we will surely imbibe her message. Let's unite together to eliminate the deadly cancer. I would like to express my profound gratitude to our guest of honor, Dr. Ram Prasad. Sir, you rightly said that by bridging the gap, we can reduce the incidence of cancer. And Dr. Madhumita ma'am, you rightly said that first step for prevention is awareness. We should aware our patient about the cancer and to adopt a healthy lifestyle. From depth of my heart, I thank our special guest, Dr. Meena, for honoring the event with her presence. Ma'am, you are always an inspiration for us. And one line for our organizer, Dr. Sadhna ma'am, behind every successful woman is herself. I am running short of words to express my humble thanks to our chairpersons, Dr. Kiran, Dr. Geeta, Dr. Archana, Dr. Bharti Mishra, Dr. Bharti Rajshekharan, Dr. Reena ma'am, for their valuable inputs and sharing their experience with us. I would like to thank our distinguished speaker for making excellent presentation and making the webinar interesting and meaningful. The take-home messages from our speaker, Dr. Chitra, VIA is better because it screens and treats. Self-sampling method is more acceptable. HPV screening is more cost-effective. Dr. Sadhna ma'am, 90% of epithelial cancer are related to genes. So family history is very important even for a male breast cancer. For high-risk women between the age of 30 to 35, TVS, CA 125 and physical examination, all three should be done. Dr. Anjana ma'am, women with endometrial cell in pap smear needs further evaluation to exclude endometrial carcinoma. Hysteroscopy should be reserved in case of negative DNC. Dr. Kanchan Sharma ma'am, aromatase inhibitors when used for breast cancer, bone health should also be taken into consideration. And the mucin vaccine, mucin 1 vaccine, when it is available, we can get rid of breast cancer and also of ovarian cancer, just like we have with cervical cancer. My special thanks to our audience, because without them, any webinar can't be successful. And my thanks to the sponsoring pharma company, and special thanks to Dr. Amrita and Dr. Babita for co-moderating the sessions along with me. Thank you all once again.
Thank you, Aruna. It is so heartening that you listen so well, and it is really itself a motivation for a speaker. So your
Thank you, ma'am.
is something exemplary.
Thank you, ma'am.
Thank you.
Very good.
Dr. Aruna.
Thank you, Kanchan ma'am.
Good night,
Thank you,
everybody.
Amrita. Thank you, everybody.
Good night,
And
everybody.
hearty
It was so
thanks
nice
our
seeing